Good morning and a very warm welcome on this Sunday morning. You are all welcome to the most sought after CMEs on first Sundays of every month. We have missed a couple of months, and the most important thing, we missed OBGY in last year. So we're going to make up today. We have the Bombay Seaward Medical Association and Bombay Medical Union in association jointly with Obstetrics and the OBGY department of Sir H.N. Reliance Hospital and Sir H.N. Reliance Foundation. Let us bring today the OBGY update. So may I call upon our President, Dr. Kamlesh Shah, to take over.
Good morning. Welcome, friends and colleagues. As the euphoria of a very successful and appreciated multi-specialty annual conference has settled, we are back with our monthly CME, which I held on the first Sunday of every month. It gives me a great pleasure to present today's CME on update in Gynaecology and Obstetrics. It is organized by Bombay Seaward Medical Association along with BMU and Sir H.N. Reliance Foundation Hospital. Our today's CME has been conceived by our past president, Dr. Vijay Kambati, covering the latest updates in gynecology and obstetrics, which will be very helpful in our day-to-day practice for family physicians. I am thankful to all our speakers, our panel. And today, there are two important things. We'll confer Lifetime Achievement Award to Dr. Sadhna Desai and Excellence Award to Dr. Dharan Gyanchandani, CEO of Sir H.N. Reliance Foundation Hospital. My sincere thanks to Dr. Vijay Kambati for organizing this CME, and above all to our scientific committee chairman, Dr. Anil Mehta, who very successfully has managed all the CMEs. I am thankful to Sir H.N. Reliance Foundation Hospital for granting their place and hospitality. I've got one announcement to make. The GPA is holding a conference, annual conference. That 51st annual conference on 9th April 23. You all can register now or wait locally. That is a post program, okay.
Yeah, I'm saying is the pre-conference CME and the post-conference CME.
Okay, so 18th and 19th March. So please register in large numbers. I now call upon Dr. Asa Dalal to take over.
It gives me great pleasure, friends, to welcome all of you here. Bombay Seaward Medical Association with the Bombay Medical Union and Sir H.N. Reliance Hospital. We've been holding these CMEs for a long, long time. And once again, Dr. Vijay Kambati has managed to put together such varied topics from infertility to menopause, along with today that nothing can be complete without artificial intelligence or genetics. So he has managed to put that into genuinely with a whole lot of you. I have such wonderful personal and professional relations. So we hope that we welcome you more and more for such programs and for even others. So a very good morning, and I won't now waste much of your time. Thank you so much.
I'll call Ashlesha to take over as a master of ceremony. She'll start the proceedings.
I extend a very warm good morning to all present. We would like to start today's proceedings with the first session, which is on genetic simplified for the clinicians. I would like to call upon the chairpersons for the same. Dr. Varsha Vaidhuvat ma'am, who has a rich clinical experience with focus on vaginal hysterectomies and high-risk pregnancies. Madam is also trained in endoscopy, ultrasonography, and infertility management. I would also like to call upon Dr. Ashwin Shetty, sir, who is accomplished European from Bristol University Institute and also certified in managing obstetrics emergencies and trauma. Good morning, everyone.
Hello. Good morning, everyone. I think we'll start our first session with Woodward back in 1940. He was an infectious disease expert in the University of Maryland. And he had given this adage for his students: when you hear hoofbeats, think of horses, not of zebras. So much so that in the years to come, zebra became a medical slang for rare disorders, often told in a demeaning manner to students: why are you thinking of zebras when there are horses? But as we move ahead from 1940 to 2023, what has changed in the last 80 years? We realized that while this is not moving ahead, we realized that while, no, it's not moving ahead. We realized that while horses and common disorders are very much there in our OPDs, in our day-to-day practice, it's time that we start addressing these rare disorders and understanding, are they truly rare? I'm going to take you through some case scenarios. Today's next 30 minutes are going to be absolutely clinical. This was a young boy, 8-year-old, presented with a large mass on the lateral aspect of his tongue. A biopsy was done elsewhere and diagnosis of mucosal neuroma was provided. Now, the pediatric surgeon who was about to operate was concerned because mucosal neuroma can sometimes be a part of a larger constellation called as Men-2B syndrome, where it's an aggressive condition with a lot of other cancers. And he was concerned, that if I'm going to resect a part of the tongue, this Men-2B is associated with very bad thyroid cancers. And mother was crying, family was dejected. Such a young boy having such a morbid diagnosis. With that background, he said that, I should be justified if I'm doing something so invasive. Why don't you just look into it? There are specific genes for Men-2B. Please help us out. However, how much ever we go into artificial intelligence, there's a human component that can never be taken away. Clinical and bedside medicine is here to stay. When we examined the child, he had huge caffeole spots all over his body. Even his mother had this large caffeole patch. A pedigree is a poor man's genetic test, often more contributory than fancy sophisticated tests. When I took the detailed family history, this is the child, his mother, and the mother's mother had died of ovarian cancer. So then you start scratching your neurons. Am I looking at a mucosal neuroma, or is this something else? Is this like an autosomal dominant condition? Because I can see vertical transmission, with variable presentations, maybe some cancers, some caffeoles. Can this be a neurofibroma? And we know that the plexiform neurofibroma histopathology can mimic mucosal neuroma. Rightly so, the histopath prove it, the genetics prove it, that this was a case of neurofibromatosis and not meant to be. And neurofibromatosis as compared to meant to be is a very manageable diagnosis. It just requires routine surveillance for some complications. Why did I choose this case today? So this patient didn't come with a placard of neurofibromatosis and I want to meet a geneticist. Very often these patients would present to other physicians. This child went to a pediatric surgeon, was screened by a pathologist, until of course the penny dropped and he arrived to a geneticist. And these are some examples where children with genetic disorders, adults with genetic disorders would come to all of us in our OPD practice, often mimicked as day-to-day complaints. So this child with some blisters actually had epidermolysis bullosa, extreme failure to thrive, had a deletion in the chromosome. Extreme obesity wasn't just due to COVID and sitting and watching screen time. It was a case of Prader-Willi, and so on. And what fact I wish to stress over here is that rare diseases can present to any specialist. With that, I would go quickly to the next case. This was a lady, you can see that she had, can we minimize this? It's blocking the screen. She had multiple family members affected with ataxia and tremors. And every subsequent generation would present at a younger age. You can see this. And she had a sister who had expired. To cut a long story short, although she had ataxia in adulthood, the telltale signs were like that of a spinocerebellar ataxia. This is a genetic disease. It starts late. Often it's neurodegenerative with early death. Point is, second point, rare disorders can present at any age. So they can present to any specialist, they can present to any age. I was talking to Vijay sir that there is a famous hashtag, 1 in 10. It is estimated that 1 in 10 of us will live with a rare disease at some point in our lives. And the third myth that I would want to bust before we start on with today's thing head on is that India is not immune to genetic disorders. On the contrary, India is an undeclared capital. For anyone wanting to do genetics, genomics, they know Namaste India is the rhythm and the rhyme to go on to. There was this huge study which was conducted which said that because of the popularity of marriage, the endogamy means marrying within the same communities, consanguinity. These are the reasons why every genetic disorder has been found in India. In fact, the burden of genetic disorders in India is unequal to anywhere else in the world. We harbor 1/4 of the global burden of rare disorders. And then there are these various population-specific genomic disorders, where different communities have been now studied to be predisposed to, and I'm sure this is just the tip of the iceberg. As we get smarter and dig deeper, we're now going to know, so in our day-to-day OPDs, you take a history, you know a person is of a particular ethnicity, you could start thinking in that particular direction. And so the fact 3, which I would like to bust before we begin, is that India is not an exception to rare disease. And while rare may not occur immediately, we need to remember that now rare is many. When you listen to hoofbeats, think about horses, but also look for stripes. With that little prelude, I would want to begin on today's topic, which was suggested to me about basics of genetics. I've tried to build on this, that this topic is relevant to each of us today present here. When should we suspect? Why should we suspect? And if we've suspected, how do we work it out? So there's this easy mnemonic that has been suggested, goes by the name of family genes. So in the presence, and I'm going to corroborate each of these with examples, in the presence of a family history, group of congenital anomalies, extreme presentation of a relatively common complaint, neurodevelopmental delay or regression, extreme pathology, surprising lab values. These are some of the red flags which should make us think in terms of genetics. This was an interesting case. This girl was born in 2003 and she presented to us in 2019, and she had syndromic delay, global developmental delay, failure to thrive, dysmorphism, seizures, congenital heart disease. And the pediatrician back in 2003 thought maybe she can be Edwards syndrome, and rightly did a karyotype. Karyotype turned out to be normal. And then the couple was very anxious. In the next pregnancy, they thought, no, let's take all care. They performed the amniocentesis, did the fetal karyotype, but even that was normal. Reassured, moved ahead. But to their dismay, the second child was born affected and in fact expired. While these situations may seem perplexing 2 decades back, we understand that a lot has changed in 20 years. Our internet speeds have changed. The way we look at the moon has changed. The way we look at the chromosomes has also changed. So while karyotype gives us a visual inspection of the macroscopic errors, we need to remember that karyotype is no longer the be-all and the end-all. In fact, it will not detect errors smaller than 5 to 7 million bases. And that's a huge share. And with that, I'm very quickly going to take you all through the type of genetic errors. So if I delete or duplicate this entire sentence, this is a large error, something like Turner trisomy, but there are micro deletions, micro duplications, and then there are spelling changes. So there are different types of genetic errors, and depending on the type of the genetic error, there are different types of genetic tests. We may not be able to learn this all in one day, but even if we take back home that a normal karyotype doesn't mean an absence of a genetic etiology, it is a big message that we are remembering. And there are various test platforms now. I'm going to touch a few of them. So for these deletion duplications, you have microarrays, which have come. I'm sure some of us are using that in our practice. And for the single nucleotide changes, where C has got replaced by T, causing a change in amino acid, these are called as single nucleotide variants for what we have next generation sequencing platforms. And it's like telling I have a library filled with books. I just want to know whether my Emery's textbook of genetics is present or not. I'm just doing a visual inspection, something like a karyotype may have. But has someone torn out the index page from Emery? Just a visual inspection won't help. I need a final test platform like a microarray. And if I need to find out a spell change, then I need a testing platform like a next generation sequencing. This is really an oversimplification, but it helps us to get familiar with the concepts. Very quickly, microarray is like the smarter sibling of karyotype, 100 to 200 times higher resolution. It is in fact the test of choice now for POC analysis for recurrent pregnancy losses, fetus with multiple congenital anomalies, a stillbirth or an IUFT where there's no apparent etiology, a child with developmental delays, multiple congenital anomalies without an apparent etiology. And although Bhagwan ke ghar mein der hai, andher nahi, but sometimes I think the delay is as good as a denial. This child did get a diagnosis 20 years after her journey, but I think it was too late. She had a dual 1p36 deletion along with a duplication. We can just imagine if this test was available 20 years back, maybe the family structure would have been different today. Family history is one of the easiest signals we clinicians will pick up. So like this was a case of a lady who presented with early breast cancer. Important that we don't just dig into the maternal side of the family history. She had a Bua who had also had pre-menopausal breast cancer. She had a Nani who had expired of ovarian cancer. So we need to remember that, and of course, and a relative, her brother who had, the Nani's brother who had prostate cancer. Telltale sign. This is the easiest of the ones where we won't miss it. But even for this, we need to dig deeper. It's not just that you ask, ghar mein kisi ko breast cancer hua hai, mummy ke side, but you need to dig into the entire spectrum, take a detailed 3-generation pedigree. And we need to remember that there are many such scenarios where a birth history will be the main leading point for us to think in terms of genetic disorders. However, a word of caution that while birth history is an easy giveaway, the absence of a birth history, absence of a family history should not be preclude for us to suspect genetic disorders. 80% of the genetic diseases will present without a family history, and which is why we need to remember these other parts of the mnemonic too. Group of congenital anomalies, very often we'll see either an antenatal scan that's abnormal or after birth, a child having multiple birth defects, multiple anomalies. Now here I would want to share 2 words that even if we cannot necessarily make sense of that constellation, make sense of what are these combinations pointing towards, that's okay. But initiating the diagnosis is important. Initiating the workup is important. This was a child with club feet, cleft palate, microretrognathia, that's a small and receded chin, respiratory insufficiency. And if you see the X-ray carefully, which actually you can see that there is no scapular shadow. Now, for someone who's working into rare diseases and skeletal dysplasias, this looks like a case of a skeletal dysplasia, that there is some abnormality in the bone formation with some other systems getting affected. Now, you need to not just know what is the differential, but you know what is the type of error. Lord Ram, if he continued hitting on the neck, would have never won the war at Lanka. He had to know he has to hit at the navel. So in the same way, knowing that this is likely a skeletal dysplasia, these are likely caused due to single nucleotide changes, means that I will not waste time and money on karyotype and microarray. I will go on to next generation sequencing, the spell check, which I mentioned to you. Initially, these genes used to be checked one gene at a time. But then as technology improved, now we can do multiple genes at one time, what is called as next generation sequencing, abbreviated as NGS. And there is a lot to speak. This could itself be a 1-hour talk. But what we need to remember is that this test is a platform that helps us to pick these disorders of single gene errors. And rightly so, our suspicion was right. This was a case of campomelic dysplasia. One may wonder, how did it make us wiser? Why did we do this all? So this diagnosis helped us to prognosticate. Campomelic dysplasia is not an easy diagnosis. Often the children have prolonged and stormy NICU courses. And this was a fourth of the children, father being a lower middle class family person. This helped the team to take informed decision about how aggressive and proactive they want to be about the NICU care. When we see minor malformations, major malformations, we need to remember that we need to attempt a pattern recognition. Do not ignore the minor malformations. In fact, in the presence of 2 or more minor malformations, there is a good chance that there could be a hidden major malformation. And often these are like pieces of the jigsaw, where you're just trying to get everything together so that your diagnosis can be easier and quicker. This was a case, again, in the same line of an antenatal case where the fetus had club feet, ventriculomegaly, echogenic cardiac focus. Now, this is not spelling into a clear-cut syndrome, but we know that these are too many anomalies in one fetus, number one. I need to suspect a genetic etiology, number 2. And in such a case, the test of choice is no longer a karyotype. I need to do a microarray. And when we did the microarray, it showed a gain of chromosome 6 and a loss of chromosome 7. Again, something rare, but as we start ordering these tests, we'll realize that rare isn't all that rare. In fact, as per a study on birth defects, it was found that amongst all the patients who did find an etiology, more than 90% of the birth defects were related to genetic causation. Coming to the third part of the mnemonic, extreme manifestations. So we would see a child with recurrent fractures, but if a child is getting fractures even with the push of a sibling, with minor trauma, and club that with fragile bones, blue sclera, some hearing loss, you know you're thinking in terms of osteogenesis imperfecta. And why is this important? Because timely initiation of bisphosphonate therapy can really change the fracture frequency and make this child's life more tolerable, improve his quality of life. There are many such scenarios of extreme presentation. Asha ma'am may remember this patient. It was, we had worked together on this. This was a lady who was gravida 3, 2 previous abortion, and in the current pregnancy, she actually had a large gluteal abscess. Just prior to the gluteal abscess, 1-2 weeks prior, her NT scan and everything was bang normal. Underwent the procedure, and the next day, when they just did the scan, no fetal heart rate. You can imagine, I think the doctors were in as much of a horror as the patient, because we can understand the thoughts that cross our mind at such times. Send the karyotype, but the karyotype failed. And this can happen. 20 to 40% of the karyotypes could fail because there isn't enough growth happening. And this requires living cells, whereas microarray does not require living tissue. So we sent the microarray, and lo and behold, this was a case of a large gain of chromosome 13, like a partial trisomy 13. I'm sure this pregnancy was to move ahead. Some of the other scan findings would have come up, to alert us. Point is that such extreme presentations, you're not expecting recurrent miscarriages, extreme obesity, especially in a young age child, premature ovarian insufficiency, extreme failure to thrive. We can go on and on. So when we see a presentation that is an outlier of the otherwise common presentation, we should think in terms of genetic etiology. Coming to the end part of the mnemonic, that's neurodevelopmental delay or regression. I think for the obstetrician colleagues in the audience, this would be more important when you're taking a detailed family history. You see that there's an older child or a very close family member who has one of these. Cerebral palsy, I would say, is one of the largest pitfalls. As per a recent study, all conducted by Chopra et al. In UK, published in 2022, 25 to 30% of the children with cerebral palsy, even those who had a clear-cut etiology, had an underlying genetic causation. You can imagine the huge medico-legal fallout of this. Often we doctors, obstetricians are soft targets for cerebral palsy and the emotional issues that follow. This was a child, actually. These two cases will be surprised at the same diagnosis, but separated by continents. This was an uneventful birth, had global developmental delay, seizures thereafter, but despite this very, very clear perinatal period, he was labeled as a cerebral palsy. The penny dropped at 2 years when someone did an MRI, suggested a glutaric acidemia. Glutaric acidemia is an enzyme disorder. It is a genetic disorder which can easily be treated if it is picked up in time. However, by this time this child came to us, he was having multiple status dystonicus, profound delay, and really nothing could be done. Now, contrast this with another child living in the US. Of course, and you can see even she had glutaric acidemia. Newborn screening had detected it, and today she's on medical food, vitamin supplements which are known to help these disorders, specific vitamin supplements, and she's normal, going to 4th grade and enjoying life like any other kid. So I think early diagnosis matters. We are no longer in an age where genetics is just about the next child. Genetics is very much about that same patient too, about his or her quality of life, about giving them a treatment when it is available. Coming to the E part of mnemonic, the second last part. So this was a child, of course, extreme pathology, oily stools, failure to thrive. To cut a long story short, he got diagnosed with cystic fibrosis. And while this child had 5 episodes of admission in the preceding 12 months, following diagnosis by prophylactic pulmonary toileting, by pancreatic enzyme replacement, this child's quality of life really improved, started going to school, gained weight. In fact, now there are CFTR. The CFTR is a gene modulators. Of course, it's a challenge because it is mutation specific, age specific. But we really, with the advent of therapy, with the advent of diagnostics, the onus of early diagnosis actually lies on us. Quickly going on to surprising lab values, this was a child who was actually being treated as rickets for lots of years until they came to us when they were planning another child. And I saw that at the outset, the first report of vitamin D, which was done in him, was extremely elevated. That's pretty contradictory to what we're expecting. This was actually a case of vitamin D resistant rickets, easily treatable by just changing the formula of vitamin D that you're giving. This child had actually lost a lot of years because people just kept labeling him as vitamin D deficient rickets. So this is an indicator. This could be seen in our practice. It could be a abnormal Menser's index. It could be something else which could. So surprising lab values can also be sometimes an indicator to a genetic disorder. Why do we need to pick up these conditions in time? Firstly, while a large share of them will present in childhood, we need to remember that these disorders can even present in adulthood. They will mimic common disorders. This was a study which was done in the US where they showed a patient with rare disease on an average takes 7 years to arrive at a diagnosis. In this period meets at least 8 physicians, 4 of whom are at least super specialist or above. And even at the end of it, nearly half of them are misdiagnosed. So that is a challenge that we are living in, that we need more sensitization despite the best of the efforts. Sometimes these diseases do not get diagnosed, and delayed diagnosis, as I said, can sometimes mean denial. A child who has a treatment, has missed important years of neurodevelopment. A family who could have had a second normal child is now stuck with 2 affected children. So delayed diagnosis can really be unforgiving sometimes. And that's the reason why I come to the last segment of the talk. Why this effort? Why are we even caring to know about rare disorders? Of course, firstly, we all know that a lot of these genetic conditions, while some of them can be sporadic, they can even be inherited, which means that there can be a risk of recurrence. However, a word of caution over here, a clinical diagnosis is not enough for us to prevent a recurrence. So I remember cases, families telling that, we had a previous baby, the paper says it is colloidal baby, why can't you now prevent it? I have a previous paper which says my baby had a skeletal dysplasia, but quite like how Sherlock Holmes had his obsession for fingerprints to prove his cause, to prove his theory, we geneticists are obsessed with the genetic fingerprint, what is also called as the mutation. So without this mutation is impossible, because there could be so many genes. Within the gene, there could be so many variants. What is a specific family variant? And once you have found that, It's like your Da Vinci Code decoded, then you have everything light off simple. Once you have a definite mutation, you can do the amniocentesis or the chorion villus sampling, check the fetal cells for the targeted family specific mutation. If it is present, you counsel the family. What is the disease? Should the child be attempted to take a birth? Can it be managed, or no, it's very morbid and I would rather discontinue? Also, we are living in an age, today's session is going to have some very interesting talks about the progresses of infertility care and artificial reproductive technique. We are at an age where the egg and the sperm can be taken, the embryo can be formed, and this embryo can be screened for the faulty mutation, and only the healthy embryo can be implanted into the mother's womb. Of course, a mandate for all this is first that you need to know what is the confirmed gene, what is the confirmed mutation. Without that, we cannot proceed. The next part is, of course, to know what is a family risk. So I always say genetic medicine is just same like family medicine, because you never will look at just the patient. You have to look 360 degrees. If I've diagnosed a case of BRCA, does she have children? Does she have sisters and brothers? Do they have children? What is the risk to the other as yet unaffected family members? Can we give them surveillance? Duchenne muscular dystrophy, we'll say that the lady who has passed it will not get DMD. Very right. But 20% of the mothers will get dilated cardiomyopathy. So you have to look at what impact does a diagnosis have on the rest of the family members. It is very heartening because over the last 10 years since we are into creating awareness, this segment of treatable genetics has really been growing by leaps and bounds. You'll be surprised. We often say, why pursue genetics? It's so expensive. A patient is just wasting money. This was an interesting paper published in 2017, where they said that on the contrary, timely genetic test can actually save 6 to 7 years and nearly $19,000 per family. Imagine that family who had glutaric acidemia, they had done some 3 MRIs, multiple doctors, and versus that the cost of treatment. So we need to shed off this old skin and understand that timely diagnosis matters. It's not just about giving the family a risk of recurrence, but even improving the child's quality of life. This was a child who presented in our outstation OPD. He had autism ADHD. Autism ADHD is on the background. We are not bothered about that as per the family's perspective. They came to us because they were planning another child. But when I took the history, what do I find? This child had history or episodes of 3 intercurrent illness triggered encephalopathy. And for those who are in pediatrics and NICU care would understand that there's something called as inborn errors of metabolism, where a particular enzyme is missing and really under periods of stress, it can create havoc. All these telltale signs showed that this could be an inborn error of metabolism. And I didn't know whether I should feel happy or sad that our suspicion was right, because this is a treatable disorder. Getting to know at 7 years of age, and even within starting the therapy, although it was too late, we know that 95% of our brain is formed in the first 5 years. We had a teleconsult. This was during the COVID times. And after 6 months of this targeted therapy for maple syrup urine disease, this child actually had improvement in hyperactivity. His cognition improved. Imagine if the same thing was offered to him at 6 months when he had his first episode of encephalopathy. The family wouldn't be dealing with an autistic child today. And all genetic diagnosis treatment are not worth 17 crores like spinal muscular atrophy. We often tend to believe genetic therapy means it has to be expensive. It could be as cheap as a strip of pyridoxine, which costs just 26 rupees. So we need to understand that all genetic therapies are not expensive. There are a lot of which can easily be treated only if we diagnose them in time. There are more than 110 treatable causes of intellectual disability. And we are in an age of precision medicine. Now it is, oh, you have SCNA1 mutation, so I'm going to give you carbamazepine. You have SCN3A mutation, so I will not give you carbamazepine for your seizures, rather I'll give you something else. So we are in an age of precision medicine. And of course, I was discussing with someone at the start of the talk. Genetic scissors or CRISPR-Cas9 technology is already here. We have gene therapies for many diseases now, including RPE65. You have the spinal muscular atrophy. How do these ethical and legal matters unfold in the years to come would be very interesting to note. So other than this, of course, I think if nothing convinces us It's often said we look at a patient medico-legally first and then medically. In a recent survey, failure of duty to refer was the commonest cause of grievance raised by the patient. So if we feel that this is genetic, or if we feel that this is, if I am a geneticist, it's an oncological issue, it's beyond my purview of expertise, you refer, because that is our duty as physicians to refer. And this was the second commonest cause of litigation in a recent survey, as I said. Of course, preventing complications, and as I said, it could actually end up saving time and money. So I've finished in time, and I would just want to say that Harry Potter, for those who are Harry Potter fans, he used to have this invisibility cloak. And I'm very sure genetic diseases also have this. They will not come to the OPD, in easy diagnostic modules. We need to start thinking of what lies below that invisibility cloak to give families and to give patients a better quality of life. Thank you so much. Thank you. Yeah.
We see over here.
Yeah.
They want to know the area of the next pregnancy.
Right. So yeah, autism has started, the prevalence is now increasing in the urban sector, sir. And as per recent studies, 20 to 30% of these could be due to known monogenic disorders. 15 years back, this was 5%. And I'm sure in the next decade, this figure will go up. Point is that not all autism is genetic, and not all autism that is genetic can be picked up by the current platforms. And if we, given our best, if we pick up the variant, then as I said, we have an easy route for prenatal. Otherwise, we cannot help much. They have to go ahead with the empiric risk of recurrence of 15 to 20%, usually in these cases. We just recently have concluded, where I was on the OI-PI team, where we have sequenced 150 children with autism. Their genetic sequencing has been done. The results are awaited. Maybe next time when I meet, I'll tell you what is our experience of autism and the genetic burden, sir. So. No, not at all, sir. So which is why I put this pedigree, mother's side and father's side. In fact, even a sporadic cancer. It could be seeming that this is the first time, but any breast cancer that is premenopausal, that is bilateral, every ovarian cancer, there are these risk factors. So colon cancer, that is early age. So these are the risk factors irrespective of family history. We should be initiating a talk with the patient about the possibility of this being genetic. I know it may scare them off, but they're already scared, and it's about giving them the right to know that this could be genetic, basically. So, yes, sir. Yeah. Thank you so much. Thank you.
Thank you, ma'am, for the wonderful session. We would like to have a session on the prevention of cervical cancer. For the same, I would like to call upon the chairperson, Dr. Vijay Kamati, sir, who is the Secretary of Government Medical Association, Dr. Priya Gora, ma'am, who is Managing Council Network and Honorary Secretary of Association of Medical Mumbai.
Thank you.
Sarita, I would like to thank you very much for the last minute addition.
No problem.
And I'm also thankful to Aisha for allowing me. The two of the speakers say that they will be late, so we have to raise, and she was good enough to last minute. Yesterday only he said, okay, I'll speak for some time. Thank you very much, Sarita.
No.
I would ask Priya for giving.
With great pleasure, I want to introduce Dr. Sarita Bhalirao. Madam is a governing council member of the ICOG. She's a joint secretary of POXI. She has been at 2017. A past president of AMWI Mumbai branch. And she is the chair of AICC RCOG West Zone. And a past chapter secretary of the Indian Menopause Society. She will be speaking on a very important topic on prevention of cervical cancer.
I think they're just having a little technical issue. I think it is seen here. Worries. So, good morning, ladies and gentlemen. At the outset, I'd like to thank Dr. Khambati, Dr. Asha Dalal, and the C-Ward President, Dr. Kamlesh Shah, and Dr. Anil Mehta for giving me this opportunity to speak to you on cervical cancer prevention. So I think I'm okay. You can just see it here. I'll move it from here. Don't worry about it. Huh? Just tell me this moves how? This one?
Yeah.
Yeah, okay. So I'm going to talk to you on cervical cancer screening and prevention.
Just give me
Yeah. So despite all our efforts, cervical cancer still remains a leading cause of cancer in women. And in our country especially, we have a problem in the Western world, in Europe, in Australia. They have brought down the incidence of cervical cancer with their tremendous screening efforts. Now, what is the problem? So, cervical cancer is still a big problem, as I said, and the age standardized incidence is 22 per 100,000 per year, age standardized mortality. But these figures really don't mean so much. It is still a second leading cause of cancer deaths among women. And the sad story is that out of the global cancer deaths, a large number of them are occurring in our country. And when we look at Indian statistics, we know that the burden of cancer has doubled. Though breast cancer is very high, cervical cancer has decreased. We have been made a difference, but still there is a huge burden of cervical cancer. And cervical cancer is today a completely preventable cancer. These are the figures just to show you how Australia, United Kingdom, and look at the United States, where currently CA cervix is not amongst the top 10 cancers of USA. They have really brought down the incidence. So I think that we really have a lot of things we can do. When we look at the targets, we have definite targets, and the vision is a world without cervical cancer. A goal is to go below 4 cases of cervical cancer per 100,000 women. And these are the 2030 targets, where we want 90% of girls fully vaccinated by the HPV vaccine by the age of 15, 70% of women screened with an HPV test at 35 and 45 years. And the important thing is all of them should be managed appropriately. So not just do we screen, but we also have to manage them. And 90% of women who are identified with precancerous lesions should receive adequate treatment and follow up. And this is what we are working towards. So how do we screen for cervical cancer? And I think the first one that I put up is the visual inspection of the cervix. A good visual inspection of the cervix is really very important. These days, we are in our consulting rooms with dark light and we're doing sonographies, but with a good light, a good magnification, first thing is look at the cervix. If it looks abnormal, if there's any lesion, then it needs to be evaluated further. We also have to do the pap smear, the traditional pap smear, and now the improved version of the pap smear, which is the liquid-based cytology, colposcopy, treatment of precancer, and now the advent of HPV DNA testing has made the situation simpler. But all of these together are very important. Individually, they are fallible, but collectively, they are very valuable. So managing and screening for cervical cancer is a comprehensive thing. Now, the pap smear is the first very important thing, and you can see this is the spatula. It is effective, inexpensive, very acceptable, and very painless. And we just take the IR spatula and take the cells, put it on a slide, send it to the microscope. But the pap smear has certain problems. Though it is a highly specific screening test, it will give us good results. Unfortunately, it can sometimes be normal even when the patient has a lesion. So that is the problem, that sometimes we need a better test, because we have had patients who have a normal pap smear and then they develop cervical cancer. So the sensitivity of the pap smear is not up to the mark. Also, it has to be taken well. We need a laboratory good backup, and there is a necessity because of this to do repeated smears, that you have to do an annual pap smear screening for all our patients. The liquid-based cytology is an improvement over the traditional pap smear. And here you can see that we have the little bottle and the brush. And here the sampling errors, the preparation, interpretation errors, it gives you better reports. And this is an improvement over the traditional pap smear. What about colposcopy? Colposcopy is a technique by which we look at the cervix with magnification and with light, and it allows direct assessment by the clinician of the entire lower genital tract. Here we can differentiate from low-grade lesions from high-grade lesions, and it allows us to plan treatment. What we can destroy the area which is abnormal. If there's a small abnormal area, it can be destroyed, or it can be excised by what is called the large loop excision procedure. And it is very valuable even for follow-up. So when we do a colposcopy, we have to see whether the examination is adequate, where to take the biopsy from, and can I rule out cancer. And this is just to show a few pictures of how the cervix looks: the squamous epithelium, pink and smooth, the columnar epithelium, which is red and granular, and then the metaplastic epithelium. So by looking at the cervix, you can get an idea of the architecture of the cervix. And this is what is called the transformation zone, which is where the lesions all begin. So this is just to show you how we do the colposcopy. We look at whether it's a type 1 or a type 2 or a type 3 transformation zone, and look at the architecture of the cervix. So then we put acetic acid, which is basically vinegar, 3 to 5% acetic acid, and see that areas which are abnormal will stain dark white with this acetic acid. And these are areas which may be infected with the human papilloma virus or may be neoplastic. This acetic acid coagulates the proteins and makes the epithelium white. It dehydrates the cells, and if it is a sharp aceto-white area and it is well demarcated, it is more suggestive of a neoplastic lesion. Then we come to HPV testing, and at this stage, I'd like to mention Harold Zurhausen, who got the Nobel Prize in 2008 because he discovered the role of human papilloma virus. And he said that HPV 16 and 18 initially were the ones which cause cervical cancer. And this is the first time that it's a viral cause of cancer. Now we know that there are many other subtypes also, but there is a group of HPV subtypes which are called HR-HPV, high-risk HPV subtypes, which cause cervical cancer and these lesions. There are also low-risk HPV subtypes which don't cause cervical cancer. So that is important. And if you look at the slide on the right-hand side, you can see the natural history of HPV infection, which shows that first the cervix is infected with this high-risk HPV subtype. Many patients clear the virus over 6 months, 1 year, 2 years. Almost 90% plus patients will clear the virus. Only a few patients will have persistent HPV infection, and there's a long time interval, approximately 10 years, from when the person is infected with HPV to the development of cancer. And that time is very, very important for us. We can pick them up and we can treat them before they develop cancer. So this was a complete game changer and led to a completely new thinking. And today we know that if we test a patient for high-risk HPV, and if the patient is high-risk HPV negative, there is a very low risk, almost negligible risk that she will develop cancer. Whereas if she is HPV positive, she may still clear the virus, or it may remain persistent. So this is the group of patients that we need to follow very carefully. And that's what led to the concept of doing not just pap smear, but also HPV testing, which is called co-testing. And from that stage, we have now come to the stage of primary HPV screening, where many countries in the world have opted for only HPV screening. And they check the patient for HPV. If the patient is HPV negative, they send the patient back and say, come after 5 years. If they are HPV positive, they follow them up much more carefully. They do a pap smear and they see if that HPV is actually causing an oncogenic process or not. So randomized trials have shown that high-risk HPV tests have greater sensitivity than cytology. They offer greater protection against cervical cancer. The big advantage is that screening intervals can be safely extended. But remember that we will be picking up many more patients because HPV is a very common infection. And cervical cancer is a rare outcome of a very common infection. So we have to look at HPV along with liquid-based cytology and use our armamentarium of colposcopy and biopsy as well. So possible outcomes of HPV infection, as I said, are clearance, which is the most common, persistence, and sometimes progression. It's very, very difficult in practice and for us to counsel these patients. And because HPV is a sexually transmitted infection. But what important 2-3 lines, and I just put a slide from at the bottom which shows how the HPV test, these are the reports we get, high-risk HPV detected. And the first thing patient will sit in front of you, why have I got it, how have I got it, do I have cancer? So we have to sit down and counsel them. We have to tell them that HPV infections are transient, will be cleared in 2 years. The moment they've come to you, they've read on the internet and they feel they have cancer, but that's not right. A positive HPV test does not mean the women will develop cancer. In fact, cancer is a rare outcome of this very common infection. And further tests, careful follow-up, and treatment is necessary so that she does not develop cancer. I think these 3 points, if we say, then they will look at. So what do we do for HPV positive patients? We have to watch them carefully. We have to avoid over-treatment, do no harm, and really we have to follow them up very carefully. So this is a very nice article again, which said that primary HPV screening for cervical cancer, this is from AIMS in Delhi, and they have suggested that we should do only HPV screening and then go on to triaging these patients to other things. So the high sensitivity of the HPV test makes it ideal for population-based screening. Primary HPV screening can be done 5 yearly. They've said 25, but now our guidelines say 30 plus. And in order to eliminate cervical cancer, it is recommended that each country should achieve at least 70% of screening coverage
by an effective screening test by 2030, and these lesions, 90% should be treated. The most important reason why I put up this slide is that HPV test positive does not imply disease, and the woman has to be evaluated further. Also, there are a lot of HPV tests. We have to have standardization of these tests. So what do we do for treatment? If there is an abnormal area, if there is CIN area, that is cervical intraepithelial neoplastic area, either we can excise the area or by doing a loop excision, or we can burn the area by either thermocoagulation or by CO2 laser. And we also have very clear guidelines now for resource-based screening. I think another very exciting area which will be of interest to you all is the area of vaccination. And vaccination today is really very, very important. In November 2016, Delhi and Punjab started vaccinating schoolgirls. Slowly, many of the states have put it in their local programs, but it's still not in our national program, but it is very easily available. And what I wanted to show you is that now we have the quadrivalent vaccine, that is the Gardasil 4 vaccine available, which covers for HPV 6, 11, 16, and 18. It is for women from 9 years to 45 years. 2 doses are recommended in girls 9 to 14 years at 0 and 6 months. It's not to be given in pregnancy, but it can be given in lactating women. And an improvement over this is now the nonavalent vaccine, which covers 9 different subtypes of HPV. So it is covering 6, 11, 16, 18, which were earlier covered, plus it is covering 31, 33, 45, 52, and 58. It is licensed at the moment for girls and women 9 to 26 years. And 3 doses are to be given 0, 2, and 6 months. It's also licensed for boys 9 to 15 years, because we know that HPV-related cancer in men, it causes penile cancer, anal cancers. So it is also now licensed for the boys 9 to 15 years. The cost is still about 9,000 per dose. So the cost is a little high, but we hope that it will come down. And the light at the end of the tunnel is that Serum Institute of India, as you all know, launched its first made in India HPV vaccine for cervical cancer called Cervavac. We are all waiting for it to come into the market. It has not yet come. But one hopes that once this comes, HPV vaccination will come into the universal immunization program and become a necessity. Many patients ask questions. Can I take the vaccine? Am I too old? If I'm in a monogamous relationship, do I need to take the vaccine? Do I need to be tested for HPV before taking the vaccine? And the answer is no. They don't need to be tested. Yeah, they don't need, if they are falling within the age group of 9 to 45 years, they can take the quadrivalent vaccine. 9 to 26 years, better to give the nonavalent vaccine. Do I really need the vaccine? Is it really costly? So many of these questions we are getting in practice. But I think that once you start the dialogue, many of my patients, I start the dialogue when they come for something else, PCOD, young girls. And I say, think about it, come back. And they do come back and get vaccinated. So just to show you 1 or 2 cases, this is a 45-year-old patient where she had a lesion. Cervix just showed an erosion. When the pap smear was done, it said a high-grade squamous intraepithelial lesion. Then a colposcopy showed an abnormal area. HPV testing was done, which was HPV 33 positive. That area was excised by a large loop excision, and it was reported as CIN 2 and 3 microinvasion, not seen margins free. So this patient got away with a simple hysterectomy. We were able to prevent invasive cervical cancer. And here, this is the surgical pathology report, which showed a high-grade lesion with no invasion, and the margins of resection are free. So this is what the colposcopy reports look like, where we do a green filter, acetic acid, and cervical cancer seen. Today, we have newer colposcopes, portable colposcopes, compact, portable, easy to share the images, easy to explain to the patient. And I think it's really an armament, one of the good armamentariums for any gynec clinic. And the bottom line of all this is that we have to go out. We have to go out into the periphery. We have to go out, create awareness, and it has to be part of a public health initiative. So the light at the end of the tunnel is prevention, early detection, public education, HPV testing, HPV vaccines for primary prevention, increasing role of colposcopy. Thank you very much. That you look okay. You give me back my pen, please.
I would request
Group of Hospital. She has been conferred on her with lifelong Professor Emeritus in Obstetrics and Gynaecology. I would also like to call upon Dr. Devki Kotwal ma'am, who specializes in gynecological endoscopy, infertility, and high risk of stroke.
Good morning, everyone. I think Dr. Rosa Serious doesn't need an introduction, but he's a gold medalist in his PG exam, and he has served as a scientific chair of the largest FIGO World Conference organized in Rio de Janeiro. He has lots of publications under his name, and is one of the top practicing gynecologists in the world.
Thank you, Dr. Dawa, chairpersons. Thank you, C-Ward Association and HN Hospital. And I can see what a dedicated group of clinicians you are to have an audience filling the entire hall on Sunday morning. So when Vijay called me up for this presentation, we somehow found that a book of mine had come out 2 months ago, and he specifically asked me to speak on menopause. Usually I'm asked to speak on other subjects, and thank you very much. So German Greer said you can't postpone the inevitable. The whole thing about women is that they change. Men, poor old things, seem to go on in the same groove for their whole lives. How boring. So this was a landmark day, a landmark event on the February 13th, 1963. My God, I really think it's almost like we're going to have an anniversary soon. Mrs. PG was 52 years old. She visited the rooms of Dr. Robert Wilson. He said her breasts were supple and firm, carriage was erect, good muscle tone, no genital atrophy. Skin was smooth, pliant as a girl's. Her cycles were perfectly regular and synchronized. He writes this in his book, Feminine Forever. There was a whole group of women at that point in time who had just started on something new, the birth control pill, and someone forgot to tell them to stop. He went ahead from this he decided and said that maintained that menopause was an estrogen deficiency state, which should be treated with estrogen replacement therapy to prevent. And he said something very crudely and obnoxiously termed it as the inevitable living decay.
We don't know what would have happened today if a doctor ever made that kind of a statement. So today I speak on the modern mantra for managing menopause. And primarily, I'm going to focus on stories, and I'm going to focus on the reevaluation and the rehabilitation of MHT, menopause hormone therapy, which is what we now term, which is the term we are supposed to use for HRT. 2002, something quite dramatic happened. There was this amazing study called the WHI study, 160,000 women, launched in 1991, went on till 2010, 5 major studies. Now, there was one part of this study which looked at 16,000 healthy volunteers between 50 and 79, and they were studying cardiovascular benefit. And they found that there were problems. There were problems with more breast cancer, with VTE, and that study was suspended. And you can imagine the backlash against HRT. Because the media went to town and suddenly women were worried about cancer and doctors were even more worried, so they backed off. And HRT went through a downturn. Fortunately, good sense prevailed, and this is a statement by the Canadian Society, and they kind of did an analysis, and they said, now, so we have to be more nuanced. So they said, if you look at CHD, you had 7 cases more per 10,000 women, strokes 8 cases more, VT 18 cases more. You're talking about 10,000, and CA breast 8 cases more. But look at the benefit on osteoporotic factors, on CA colon and CA endometrium. So then the wisdom and manner of terminating the trial was questioned. They said the absolute risk of HRT was very small, that it was inappropriate extrapolating your results between populations. I mean, you are giving HRT to women in their 60s and even older. And there was a generalization of results to all HRT preparations, which was wrong. Secondary analysis showed that CHD actually was reduced in younger women and in women where HRT was given in less than 10 years since menopause, and there was no increase of stroke in younger women. Another study went a little deeper and said that when estrogen alone was used with a 10-year follow-up in the study post-hysterectomy, well, actually, CHD was a little less, and even breast cancer was not significant. They said the median period of 5.9 years, that's 5 years of use, was not associated with any increase in IHT, stroke, VT, breast cancer, and mortality. And when patients ask me about breast cancer, you got to give them numbers they can understand. So I tell them for the first 5 years, you don't need to worry. And I really haven't generally used HRT for more than 5 years. And after 5 years, an additional 2 cases per 1,000 may be seen over 5 years, and up to 10 years, you see additional 6 cases per 1,000. So you've got a balance of this risk-benefit ratio. And remember, this is balanced off by less colon cancer, less osteoporosis, less hip fractures. So this was a statement by a representative in the US House who said, if you get 6 menopausal women together, you find that their doctors are doing 6 different things. Our joke is you might as well go to a veterinarian. So I think we need some more consistency. Of course, it's also important to understand we need to individualize. Hormone therapy has to be tissue specific. Hot flushes and sweats, nothing like estrogen. Improvement of mood, libido, and sexuality, estrogen and androgens. Urogenital epithelial thickening has to be estrogen, and so on. So for endometrium, progesterone is better, not estrogen. For prevention of osteoporosis, estrogen, we still don't really have the treatment of osteoporosis. We need an anti-estrogen to protect against breast cancer and to prevent cardiovascular disease. For venous disease, androgens, no estrogens, arterial estrogens, androgens, so on. Alzheimer's, we are still looking at, there are studies, even one recently, which said that estrogen was great. The 3 major groups you need to be aware of about which we are privileged to have is estrogens, which are agonists for the estrogen receptors. Tibolone, we've somehow forgotten this drug. In fact, even the main brand available is no longer available. I still use it, not very often. A selective tissue estrogenic activity regulator, what we call as a STER, which works differently on different tissues, and raloxifene, which is a SERM, which is an agonist for depending upon the tissue involved. So primarily great for bones. Preparations, we have all these preparations. I mean, you know it. It's great that we have a choice. And what I'm really thrilled about is finally in India, we have almost all the choices. The patch was taken away from us. But thankfully today I do have a transdermal cream, which I use quite liberally, which is the transdermal cream mentioned there, which is 0.75 milligrams per pump. I usually use 2 pumps. Don't forget the levonorgestrel intrauterine device. Progesterone is often blamed. Progestrogens are blamed for a lot of the negatives, and you actually can use endometrial protection with a local progestrogen release, and you don't have to suffer the other effects, and you can still have all the benefits. And of course, the transvaginal creams. We do have a group of compounds today which we need to be cognizant of and aware of, because there are still women who will not want to take hormones. And today we have phytoestrogens. Well, I tell my patients that nothing can work like estrogen when you really need it, but phytoestrogens are bioactive compounds, not considered nutrients, but have health benefits. They have estrogenic and anti-estrogenic effects in different parts of the body. Isoflavones are the most, there are 5 different types of phytoestrogens, are probably the most interesting class. And they are found in diet. It doesn't even be, it's time we started being more holistic and talking about diet and other stuff with our patients, not just prescriptions. And finally, you have affinity for the estrogen receptors in the important brain, bones, bladder, blood vessels. It has an anti-estrogenic effect on breasts and endometrium. And I often tell my colleagues, the oncologists, this, the first thing an oncologist will tell a patient is cut out soya from your diet, it's got estrogen. But actually, studies tell us quite the opposite. And finally, it has actually got cancer enzyme inhibitors and an antioxidant effect. So today, my talk is primarily going to be a few stories. I'm going to share some real stories of my patients. Ben Ockrey has said, stories can conquer fear, you know, they can make your heart bigger. So let's start with the modern mantra for vasomotor disturbance. If there is one dramatic entry into menopause, it's vasomotor disturbance. It starts years before in the perimenopause and the premenopause. And Vera Nazarian has said, the sunrise paints the sky with pinks and the sunset with peaches. Cool to warm, so is the progression to old age. She could be describing hot flushes. So Kay first met me when she was 42 years old, positive temperament, exercised regularly, amazingly fit, and suddenly her life was disrupted. Distressing, uncontrolled bouts of flushes and sweating. She was still menstruating with irregular periods. Her FSH was 34, suggesting she was perimenopausal. She had a workup in counseling, and we started her on MHT. Now, the first thing you tell a woman having flushes is, and women do it, women are smart, that they will start doing stuff to take care of their environment. They will have the air conditioning set to their convenience. Of course, their husband would be shivering next to them. That's a different story. Lightweight, loose-fitting clothes, dressing in layers, cotton sheets and bed covers. There's something called a gel mattress, which works very well. And of course, nothing like yoga, meditation, and slow abdominal breathing. For menstruating perimenopausal women, the combined oral contraceptive pill is menopause hormone therapy. They need birth control. Women forget in their 40s that they still need contraception, and they sometimes come to us pregnant because they thought that they couldn't get pregnant. Today, we have extended use up to 50 years, and I've always told women OC pills are extremely safe. Some women are dangerous, so just leave out the dangerous women and you can continue to use it. My preference is for drospirenone, but I love the idea that we've got so many different things to play with. If there's a risk of venous thrombosis, the second generation is better. The levonorgestrel is better. For bleeding issues, a desogestrel is probably better. And I will always start off with a 30 microgram dose and drop it to 20 micrograms. Why 30 micrograms? Because 15% of patients will break through with 20, shakes up their confidence, give them confidence for 3 months, bring them down. If 15% breakthrough, take them back to 30. Contraceptive patch would be great. It's not available. That's one thing I'm waiting for in our country. A few of my patients do get them from overseas. Give it on for 1 week, 3 weeks at a time. And I often use my OCs extendable. Now, most of my patients are taking the pill for 42 days with 7 days off. Anything more than 42 days, I see more breakthrough. And progesterone only pills are also an option for women who can't take estrogens. Desogestrel is getting more difficult to get nowadays for some reason, but we now have the 4 milligram drospirenone pill which can be used. Postmenopausal women the woman with an intact uterus has to have a combination estrogen and progesterone, but the progesterone is only protective for the endometrium. Without the uterus, she only needs estrogen. What if she can't take estrogens? Do you let her suffer hot flashes? Absolutely not. You've got some non-hormonal treatments. I've used clonidine. In fact, I use clonidine for every patient of mine preoperatively. It's amazing. It kind of puts them in a different space. You can use clonidine about 100 micrograms per day. You can start off with 50 and step it up. And they also have a clonidine patch overseas, which we don't have. Gabapentin has been used for hot flushes. Can be used orally. You can start with a very low dose. Most of them would do well. You know, we use gabapentin for so many things now. And finally, of course, don't forget the antidepressants. This woman needs a lot of other support, not just for the hot flushes, and everything from SSRIs to SNRIs work. And the SNRI probably would be better for the hot flushes. Paroxetine is better for the night sweats. She started on MHT with estrogen patches. Back then, we had estrogen patches in India, and progesterone symptoms magically vanished. Now, a woman relieved of hot flushes considers a doctor a magician. Trust me, the woman with hot flushes who's better in 4 weeks' time just loves you. She thinks you're magicians, but actually the estrogens are your prop. We continued for 4 years, and then she stayed on Tibolone for another 12 years. Kay, whom we call Mrs. Sunshine in our practice, continues to be a patient and a dear friend 22 years on. Coming to genitourinary health, you know, Lauren Carl Clarfield says, our body journeys through life and life journeys on our body. Life will leave marks on it. Childbirth leaves marks on the woman. Perimenopause leaves marks on the woman. And when hyperestrogenism meets the damage done during childbirth, you very often have problems with genitourinary health. And then, of course, there is all the problems of atrophic vaginitis. So Kay met me 15 years ago when she was 45. She'd been menopausal for a year, bloated and tired, frequent urination, vaginal dryness and swelling. She had been on isoflavones for 2 years, and we put her on oral estriol. Back then we had estriol. I used to love estriol. I don't know why it went off the market, and finally on Tibolone. Her only complaint since then has been vaginal dryness and atrophy, and she has been prescribed vaginal conjugated estrogen or estriol. Sometimes one is available on the market, sometimes the other. At the moment, estriol is available. The genitourinary syndrome of menopause is the new definition or the new term for vulvovaginal atrophy. Treatment has to be started early. Don't wait. Treat these women early and treat these women long term. They ask me, when do I stop my vaginal estrogen? And I say, well, almost never. Because why should she lose the benefit of something just because she's 65 or 70 years old? Where it is the sole symptom, local estrogen should be your first choice. Minimal systemic absorption is there, so she does not need a progesterone. It can actually be safely used even in women where HRT is considered contraindicated. But with malignancies, you need to talk to the oncologist, but it's supposed to be safe. Don't forget that you can also use vaginal lubricants and moisturizers. We have some nowadays. And of course, please remember to tell your patient that it's fine for her to have sex. Sex doesn't stop after menopause. Kay benefited greatly from estrogen cream, but for some reason, this woman just couldn't use an applicator. So she's worked out that fortnightly or monthly application works for her. She uses homeopathy, and for many years now, she comes, I know it sounds crazy, she comes to the clinic once or twice a month to have vaginal estrogen applied by one of our doctors. She has shown me that women know best what works for them. Even though it may not seem very scientific, we shouldn't just hear them, we need to listen to them. You know, using a cream twice a month really doesn't make sense to us, but it just works for her. And trust me, the month she doesn't come in, she's uncomfortable. Coming to cosmetic health, Denise LaFrance has said, do not dissect a rainbow. In other words, do not destroy a beautiful phenomenon by overanalyzing it. So Kay first consulted me when she was 41 years old, hypothyroid, amenorrheic for a year, grappling with hot flushes, irritable. Greatest concern was dryness and pigmentation of skin and accelerated hair loss. Her FSH was already 60, estradiol 17, suggesting a somewhat early menopause. Well, there are many different things that you can use, and sometimes we doctors need to know more than what we normally use. So there's a whole lot of preparations which have been suggested, supplements which can be suggested for cosmetic benefits. Many of these women use and we don't know about. So it's time we started reading about them and knowing what women are using. So you have alpha lipoic acid, you've got omega-3 essential fatty acids, CoQ10 is in everything nowadays, in every part of women's health. Glutathione is something women are using a lot, resveratrol and hyaluronic acid. Physical modalities, you know, a gynecologist also has to become a cosmetologist. And sometimes I have to tell my patient, you know, you need to bleach. She might have an adolescent daughter who's got hirsutism. You need to talk to her about waxing, electrolysis, but the best results come from laser hair removal following MHT. So make sure you have a number of a good clinic doing lasers on speed dial so you can give it to your patients. During perimenopause, low-dose COCs. Cyproterone containing COCs work extremely well, but I have an issue with 35 micrograms of estrogen. So I'll very often start them on it, but get them off it as soon as possible. It might be me, it might be my experience, but I find weight issues more with the cyproterone containing OC. I soon get them back onto my drosperinone containing OC, which may not be as great, but which also has an effect. But then you also have to use anti-androgens. So I'll do a free testosterone, I'll do a DHT, DHES, and my first line would be spironolactone. It's pretty safe. Finasteride and cyproterone are second line, but I do still use flutamide. I know people are so afraid of using flutamide, particularly in patients with an elevated DHT. My dearest friend, Dr. Nadeem Rice, is probably the greatest champion of flutamide. But when you have a high DHT and you have cosmetic problems, nothing works like flutamide. Of course, you need to watch the liver very closely. For hair loss, of course, you could use topical minoxidil. So she was on hormone repair therapy with a 4th generation COC, symptomatic, emotional, and cosmetic benefits, appropriate diet, vitamin D, vitamin E, biotin, moisturizer. Tell them about using a high SPF sunblock. She was put on finasteride at that point in time. After 2 years, her only complaint was vaginal dryness. At that point in time, she was switched to conventional MHT with oral conjugated estrogens, progesterone. She continues it till date and she loves how she feels. She said, I'm going to take this till I'm 50 years old. Sexual health. This is one thing your patients are distressed about, but very often won't talk about. So you've got to step up to the plate and ask them about it. Naomi Wolf has said, we do not have to spend money and go hungry and struggle and study to become sensual. We always were. We need not believe we must somehow earn good erotic care. We always deserved it. Dee was 41 years old, single mother, a year into menopause when she first met me, a fitness buff. She was committed to aerobic exercise, weight training. She looked and always dressed like a woman much younger than her age. She was petrified of aging prematurely. Started her on hormone therapy with an estrogen patch and oral progesterone, and we said we'll use this for 5 years. You have to define what her problem is. First of all, you've got to talk to them about frequency of sex. You've got to talk to them about issues. And very often the issues could be just low desire, low arousal, orgasmic dysfunction, and sexual pain. And very often sexual pain, which comes under our purview because it goes hand in hand with GSM, tends to be the first thing you need to deal with if you're going to make their sexual life and interactions better. There is today, of course, where you must also consider that there's a certain age type and time since menopause. You have to also talk about interpersonal and intrapersonal factors. It's not just about medication and hormones. It's also about her relationships. Please stop believing that sex is not important for elderly women. I mean, it's interesting that I've seen some studies where women in their 50s, more than half sexually active. Women in their 60s and 70s in the US, 30% are still sexually active. And you must always try to break the ice by very simple, open questions. You must also, of course, look at the problem of sexual pain now. Libido is always a challenge. So I'm not going to get into the vaginal estrogens here, spoke about them. The lubricants absolutely have to be advised. There's no embarrassment for a couple to be using it, but androgens have definitely a role to play. We are still looking to find their exact place in practice. There is strong evidence to suggest that androgens are what women need for their sexual function, for libido. So testosterone therapy might be useful. Before it is considered, you rule everything else out. Always start it as a clinical trial. I tell my patient, I'm going to use this for you, not yet well established. Let's see how you feel. If it benefits you, we will continue it long term. And today we have the androgen gel, which I have started using once or twice a week. I have seen results. I don't know how much of it is placebo and how much of it is real, but science tells me that it could be real, and I think we should look at it. After the withdrawal of the estrogen patch from the Indian market, she was shifted to conventional estrogen progesterone therapy. She opted to stay on it for more than 5 years. She had concerns about painful sex and diminished libido. She was in relationships. After 10 years of MHT, she decided to stay on it for 10 years, went to libido. We use Visnadine gel to improve libido, lubricants, and diligent condom use. And she continues to look younger with an active sex life. She's a role model for self-preservation, physical fitness, and confidence in addressing sexuality. Another very distressing problem, bone health. You know, T.S. Eliot has said, these fragments have showed against my ruins. Due to the, A was 41 years old when she presented with irregular menses, hyperandrogenism, hypothyroidism, and PCOS. She had earlier been treated with COC, cyproterone, and was on flutamide. After COC, we took a break and checked her FSH. She was not perimenopausal. She had good levels of estradiol. She was started on a drospirenone COC. Baseline DEXA at that time was osteopenia, minus 1.7 lower spine, advised weight-bearing exercise, calcium, vitamin D supplements, and periodic vigilance. Menopause hormone therapy can be used for prevention and treatment of osteoporosis, though it's more for prevention than for treatment. It is known to prevent osteoporotic factors even in women at low risk. It is known to increase spine bone mineral density 7.5%, femur 4.5%, and reduces the risk of spine, hip, and osteoporotic fractures by 40%. Tibolone is another option because it also has an affinity for the estrogen, progesterone, and androgen receptors, preventing fractures. But besides the hormonal treatment, because very often these patients come to us with significant osteopenia and sometimes even osteoporosis, the menopausal woman probably needs more calcium than a lactating woman. Don't forget that. I routinely believe in doing levels and I treat as per requirement, but we often see a lot of deficiency both in calcium and vitamin D. Bisphosphonates are the first line of treatment. For me, my preferred one is Risindronate, and I usually use the monthly 150 milligrams. You know, it's not an easy drug to take. Definitely not every day, even once a week. Once a month, a woman can probably tolerate it, but many women won't. And then you've got SERMs, you've got the parathormone, you've got strontium, but the other drug I've been using is denosumab. For the ones expensive. So you take Risindronate, if it works, fine. If it doesn't work, she comes twice a year and gets a subcutaneous injection of 60 milligrams. So the patient stopped the COC 4 years later, started experiencing excessive perspiration, hair loss, bone pain. By now, FSH was 21. She decided to resume the pill till the age of 50 years. Repeat DEXA had a reduction to minus 2.4. She was put on bisphosphonates. She's continuing to date. Recent DEXA showed an improvement, and we keep assessing it periodically, and we've decided that we'll stop the use after 5 years. And my final story is about premature ovarian insufficiency. Courtney Cox has said, aging gracefully is one thing, but trying to slow it down is another. S came to me when she was 27 years old. In fact, she worked with my wife. She never menstruated without hormonal medication, regular scanty menses on COCs, FSH was 72, estradiol less than 20, normal karyotype, hypoplastic uterus, thin endometrium, osteopenia. She was started on estrogen therapy. I said, stop the progesterone. And for 6 months, she took estrogens alone till the uterine dimensions improved and came to near normal, after which she was put on cyclical progesterone. Premature ovarian insufficiency is primary hypogonadism in women less than 40 years with previous normal cycles. It should be effectively treated because we know that women are exposed to the risks of CVD, osteoporosis, cognitive decline, and dementia. It's also important to tell her about her diagnosis with empathy in a very sensitive and caring manner. Mainstay of treatment is hormone replacement with estrogen, progesterone, and possibly testosterone. And this you will continue, not for 5 years, not for 10 years, but till the time when she would have reached her normal menopause, however long it takes. Obviously, IVF with donor oocytes and embryos gives a high success rate. She was given calcium and weight-bearing exercise. She was given confidence-building counseling. She was told that, be honest, very often patients want to conceal things from potential relationships, particularly if it's an arranged relationship. That's the biggest disaster, because eventually when it comes out, it completely destroys marriages and relationships. Interestingly, she met a young Muslim girl. She met this soulmate online in Australia, also a Muslim, shared the information about her condition, brought a potential mother-in-law to me and spoke about her condition. I told the mother-in-law, this girl needn't have told you. She could have been menstruating as long as she wanted with the pill, but she decided to brave enough and tell you. She's married, she's living in Australia, plans an IVF with egg donation after 2 years. Hormones will continue for another 20 years, and I have the greatest admiration for her honesty and self-belief. So I'd like to end here. I'd also like to just share with you that this book of mine came out about 2 months ago. It's written by my friend and co-author, and it's truly what I joke with her, that this book is about Ayurveda meeting modern medicine, because for once we've got a book which talks about both. Most books on menopause have bashed hormone therapy or bashed medicine and only talked about the other stuff, or vice versa. So we've tried to kind of bring balance and bring two voices. And it's all these stories are from that book, and it's a great read. And it's also something I wish many people will benefit from. Because Catherine Mansfield has said, I want to be all that I'm capable of becoming. There's so much women are capable of, and they deserve to stay that way throughout their lives. Thank you.
Thank you, Hamza. It is always pleasure to listen to you. First time I listened to when we both had fun with you oration. So you have summarized it very well. But one thing I want to say is that counseling, not only to the patient but the family members, is very important. And that is family care or many times you don't need to use the drug, but the family understanding, especially the husband and children are used to whether we have a vacant currently everything and all. They have to get into argument, and they have to be very that age. And diet, exercise, and lifestyle. That is also important.
So you're so right. It's in the book, and this is something my patients taught me and told me. So here is this woman who's been too understanding all her life. She's constantly nurtured everyone. And suddenly she comes to a point where she's not even really being difficult. She just comes to a point where she's enough. I've really taken enough, and the family finds it inconvenient. And that's not her problem. And it's extremely important to have the family on board. It's also important that she recognizes what's happening. And I will always tell her husband, who thankfully nowadays all patients come with their husband, is it's time for you all to give her the care she's given you all her life. There will be irritability. There will be blow-ups. I tell her when it's happening, just turn around and go to the other room. I tell them that when this is happening, leave the mother alone. And the stupidest thing that people will tell a woman at that point is they blame everything on hormones and menopause. The stupidest thing that husbands and people do is ask a woman, are you going to get your period because you're behaving like this? No, men don't get asked the same questions when they behave difficult. I don't see why women should. So this support is extremely important, and we've really brought it out in the book as well. And like I often say, whenever we are putting things out, is the book should also be read by men for the women in their lives, not just by women.
Question. Can you put a patient on COT for a longer time? Say after 4 to 6 months, many patients come back saying they started experiencing more dryness in the vagina. So do you feel stopping the pills for 1 or 2 months and between with help to some extent?
Yeah, so firstly, no, I don't stop COCs. I've got patients on COCs. I'm not exaggerating. For 15 and 17 years. I've never understood this taking of time. And sometimes it comes from doctors. I think it's time we also educated other specialties, because the people who kind of put patient off is the family physician, the cardiologist, the psychiatrist. The first thing anyone will say is stop your COC, which is really, you're right. Some women will experience some dryness, some women will experience a diminished libido. And you also have to see why she's taking the COC. If she's taking it for long-term contraception, find her another contraceptive method. In fact, LARC is far superior to COCs in the long term. But if she's taking COCs for menses, for other conditions, for cosmetic purposes, continue it. If she's feeling dryness, help her with a lubricant. Help her with something else. But taking a break and putting her back on doesn't make sense. I remember John Studd once saying, when a person starts seeing well, you don't tell her to stop using her glasses for 3 months a year. She continues to use them. So what's the point? If she takes a 3 month break, okay, even if the dryness becomes less, she's going to go back onto it. So find a way to continue it and help her, but there will always be, recognize what a woman is saying. If she's telling you that this is messing with the libido, this is causing her mood disturbances, and there will be very few women who will tell you that if it's causing her vaginal dryness, then find her another method. Then she needs to go to an intrauterine device. Today I've got the implant. She can go to something else. She doesn't need to do this.
What would be the role of the newer RF treatments and the thyroid lasers, vaginal lasers for?
Okay, so that's a tough one for me to answer because I don't have experience, but I can tell you that my experience came from the fact that when I was in the scientific committee of the World Congress, at one World Congress, they gave a lot of exposure and there was quite a backlash because everyone came. So we actually consulted experts, and the experts in urogynecology told us that there is some benefit, but not significant. So all the things they've been promising you are not always borne out by evidence as yet. Don't throw anything out. It may have value. It can give you short-term benefit, but I can get the short-term benefit with other things as well. And how long will this benefit last? I would rather put her on a vaginal history or vaginal conjugated estrogens and tell her to take it on alternate days for a few months and then twice a week and tell her take it for the next 20 years. No laser will do that for you, because at the end of it, you want that vaginal mucosa to be healthy, to be moisturized, to be thickened. That's what local estrogens will do. So I probably would go that route. But let's wait and watch. You know, we've seen lasers come into endoscopy in such a big way and suddenly disappear. Let's see what happens with these lasers.
Local estrogens we have been using for long, but now everything has even approved DHEA.
Yes.
Very globally. That has also given me approved.
So very exciting. So DHEA, the oral DHEA doesn't seem to have given us the same benefits, but the local DHEA has approval, and there are a few other very exciting preparations on the horizon. We don't have them. So every time a pharmaceutical company comes and asks me, what can we do for women? Let's get something for the local. Please. And the US FDA actually has one or two things they've approved, but we'll have to wait for it to come to our. So meanwhile, it'll have to be named.
Good morning, everyone. It's nice to see a full hall after a long time, a gap of almost more than 2 years. Now we have a very pleasant task to perform. Dr. Sadhana Desai, she has been very generous enough to be present here, and we are going to give a Lifetime Achievement Award to one of the senior most gynecologists in Bombay. She is a pioneer in the field of infertility and assisted reproduction in India. Emeritus Professor of Department of Obstetrics and Gynaecology, Bombay Hospital Institute and Medical Sciences. Honorary Physician to the Governor of Maharashtra. Visiting Consultant at Bridge Candy HN Reliance Foundation Hospital and Kambala Hospital. Professor and Head of Department at Bombay Hospital Postgraduate Institute of Medical Sciences from 1990 to 2009. undergraduate, postgraduate teacher and examiner in Mumbai University for more than 20 years. Past president of FOXI and ISAR, has published 80 medical papers and contributed chapters in 42 textbooks on infertility and assisted reproduction. Has given 18 orations all over India and abroad. Recipient of numerous awards, most notably the FIGO International Award in recognition of being outstanding woman, obstetrician and gynecologist from developing countries, Lifetime Achievement Award from FOXI ISAR, and MOGS B.N. Purandare Award. The Bombay Seaboard Medical Association presents a Lifetime Achievement Award to Dr. Sadhana Desai in recognition of her outstanding contribution and achievement in the field of obstetric gynecology and assisted reproduction. I would request the President Asha Dalal, ma'am, please. Kamlesh, Anil. Yeah, coming in. Yeah, there is a mic.
I thank the President and the Managing Committee of the World Medical Association for conferring me this award. I very much appreciate you.
Thank you, Sadhana. Dr. Taram is, I think, just delayed for 5 minutes. Meanwhile, I think we can start with the next one. Dr. Duru, are you ready? IT. It'll load. Yeah, Duru.
This is the file.
For the next session on unraveling the puzzle of PCOS by Dr. Guru Sharma, I would like to call upon the chairperson, Dr. Guru Sharma, who has trained in We welcome Dr. Reshma Rama, who has 4 decades of experience in obstetrics and gynecology, and Dr. Purush Swagewala, trained in cervical endoscopy and the and is a member of FOX.
And it always been a very keen academic. Really admire that she consistent years of continuous practice. Today we are very proud that she is representing India at a global level in PCOS. She's laying down guidelines along with international people for PCOS for the diagnosis as well as the management.
If you would permit me, sir, I think if you talk to Guru, you might write a second book on how to stay young forever because of the last see Guru. Very, very inspiration.
Good afternoon, ladies and gentlemen, Madam Chairperson, our seniors from the Medical Ward Association, Dr. Sadhana Desai, Dr. Rekha Gawar, chairpersons, and Dr. Anil Mehta. Today I'm going to speak on unraveling the puzzle of PCOS, because I find there's so much of confusion in how we diagnose PCOS and how we manage, and hence the decision to speak on the subject, which I would like to bring to you what the situation is, even way back in 2017, when there was a survey conducted by one of our own doctors, Anuja Dokras, who's now a university professor in the US. The American College of Gynecologists conducted this survey. Through them, they conducted, and 630 physicians completed the survey. And 30% did not know the correct way to diagnose PCOS. Many OBGYNs were not aware that depression, anxiety disorders are part of PCOS. Many were not aware that PCOS can give rise to long-term problems. And more than 85% were actually aware of associated obesity, yet only 50% of physicians recommended lifestyle changes to their patients. That is the disaster, and that is the tragedy of the situation. So physicians' education is absolutely necessary, because it's an evolving field. Till today, nobody knows what is PCOS, but there's so much of research going on that we have come to some conclusion what it is today. Maybe it will not hold 10 years later. And therefore, knowing that it is consistent and it is through the lives of a woman, it is not so simple as only treating their hair growth on the face or their acne. It is a question of taking them through their reproductive lives to a better quality of life as they grow. And hence we created the PCOS Society of India, which brings in multidisciplinary physicians all under one roof. For example, we have gynecologists, endocrinologists, dermatologists, nutritionists, physiotherapists, fitness experts, etc. And all of them have joined us to create this awareness both amongst physicians and amongst the patients. So this is the website of our PCOS Society of India, and I recommend all of you to go through. There's a lot of educational material available to all of you, totally free of cost. There are some programs which are meant only for the PCOS Society members. So that's something for which you'll have to become a member to access it. We had created the international guidelines, and I was part of it. The PCOS Society of India was invited to participate in this meeting of 39 organizations, which was headed by the American College of American Society of Reproductive Medicine and the European Society of Human Reproduction, led by Monash University. So this was something which I was part of. I was happy to be a part of this. And the way the guidelines are developed in the international world is something different from what you see is happening in our own country. This is something which takes years to develop the guidelines, evidence-based, completely on randomized controlled trials. And the effort put in on it is something unbelievable. For 2 days, a group of doctors like this, like in this group, for 2 days, we are discussing exactly 10 important questions. That's it. 10 important questions. And there are 5 such groups discussing many more questions. So, and then the whole thing put together, it's a challenge. You must go through it to realize what it means. So these guidelines are available for everyone. They are brilliant, made in 2018. And then this was, of course, I was also invited to be there in my personal capacity. And now we met again in July 2023. In 2023, it will be released, the new guidelines. And we met in November of 2022 in Florence. And that's where we were working on the guidelines, and now they are ready. They've been circulated. It will go through a whole process, and they'll be published in July 2023. So what really is
PCOS. It's called the polycystic ovarian syndrome, which it was called polycystic ovarian disease before, which is wrong because it's not a disease. It's a syndrome. It's a collection of symptoms you see. And we need to find out what exactly it means. It's associated with increased male hormones, that is androgens, increased female hormones, that's estrogen, and increased insulin levels and polycystic appearance of the ovaries. Now, whether these polycystic ovaries are the cause of the whole problem, or it's a problem which is causing polycystic ovaries, till today we are not sure. And therefore, this is something which we strongly recommend that we must know what really it is. So we must understand that it's associated with insulin resistance and hyperinsulinemia, which can then lead to impaired glucose tolerance followed by diabetes mellitus, and obesity becomes part of it. 80% of these women are obese, and that obesity and the presence of insulin resistance causes metabolic syndrome, non-alcoholic fatty liver disease, which can then lead to cirrhosis of the liver if not corrected, and increased risk of cardiovascular disease. The Rotterdam criteria were developed when many organizations got together, and they developed the criteria to say, what are we going to say is PCOS? And the first thing they said is that we should not call a woman who PCOS until she's 18 years old, or she's reached at least 8 years after her menarche. So if she's got her first period at 11, you wait for 8 years before you confirm that she's got PCOS. So in 2003, the Rotterdam criteria were developed. And the 3 criteria were that she should have irregular periods, which means less than 8 periods in a year. She should have hyperandrogenism, that is clinically she should have acne, hirsutism, loss of hair from the scalp, something like that. And the third is, and it may be either clinical or biochemical. Biochemical means today, even in the blood test which we do, whatever accurate results we get. But if you compare them to what you get through research, they may be a little different, because research uses very high-end technology, which may not always be possible in all clinical labs. And therefore, they said, and the third, of course, is the polycystic ovarian morphology. This is something I want to stress here because many of you are family physicians. And polycystic, when we see radiologists writing reports, polycystic ovarian disease, please don't listen to that. We have to call it polycystic ovarian morphology. There's no disease at all. It's only syndrome, and it's talking about symptoms. When you see an ultrasound report saying polycystic ovarian disease, means that sonologist is not updated with his knowledge on diagnosing polycystic ovary syndrome. So if any 2 out of these 3 are present, then we call it PCOS. And at the same time, we must make sure that she's not hypothyroid, she's not hyperprolactinemia, so that you do her TSH levels, do her prolactin levels, and rule out congenital adrenal hyperplasia, in which you get very high testosterone levels. So in short, if 3 of these conditions are not present, then you may, and 2 of these diagnoses are there, any 2 out of these 3 criteria are there, only then you make a diagnosis of PCOS. In the morphology, what we are looking at is that the ovarian volume should be more than 10 ml. It could be either one ovary or both ovaries, it doesn't matter. And in the past, we used to say there should be 10 to 12 follicles, but now the latest guidelines say it should be more than 20 follicles per ovary if you're using a transvaginal ultrasound of more than 8 megahertz frequency. But most of the people are still using, a lower transducer. And if that is being used, a lower frequency transducer, and if that is being used, then we say 10 to 12 follicles per ovary. Now, how does PCOS affect a girl? It basically causes problems at the adolescent period, where there could be menstrual irregularities, cosmetic issues, and mental health issues. During COVID, we found that the mental health issues increased tremendously. We did a study on that. And we found that these girls' mental health was worse because they couldn't go to beauty parlors. They couldn't get their hair removed. They couldn't get hold of anything to change their appearance. There was a lot of depression, a lot of pressure at home, and therefore periods issues, and they couldn't get hold of sanitary napkins. It was quite a challenge for these girls who bled very heavily. With the reproductive period, infertility, early pregnancy loss, disorders of pregnancy, gestational diabetes, mellitus, and pregnancy-induced hypertension are the 2 main conditions which occur during pregnancy when these women continue with their pregnancies. And then you have the 40-plus woman who can develop metabolic syndrome, and she can also develop cancer of the uterus. So if you look at what is the diagnosis, how do you diagnose an obese patient? Because if you look at this slide, over and above everything, there's obesity associated with all the ages or the age groups. And therefore, if you look at what does the guidelines say, I mean, the definition of obesity, there's a special cutoff for Asian Indians because we are found to be having more of metabolic fat. So if you see lean is less than 19.9, normal weighs 18 to 24.9 is according to international. In Indian data, we say 18 to 22.9. Overweight in international is 25.0 to 29.9, and here it is still 25. Obese is more than 30 in international, and when it comes to Indian women, we say more than 25 BMI is obese. That is the cutoff for Indian women, and that is because we find that women, they have more of visceral obesity as compared to other people, other ethnicities. Now, what really happens with the clinical effects of this obesity? It's a double whammy. With PCOS, you have metabolic issues. With obesity, you have metabolic issues. So it's a double trouble for that woman because it gives rise to early puberty. Girls may reach puberty at even 9 and 10. They have ovulatory dysfunction. They have infertility because it affects egg quality and also affects the receptivity of the endometrium to the embryo, which is coming into the uterus. There is increased androgens. There are increased miscarriages. There are maternal and fetal complications during pregnancy and labor. And this is all what we see as of during the reproductive age. Now, what causes the PCOS? Let's look at that. Now, they've been doing the genetic studies and they really haven't come to any specific gene which is going to be causing PCOS. There are a lot of mutations found in different ethnicity, different mutations. So till today, we are not able to pinpoint and say this gene if you do, you know that she has PCOS. So that is something which is not yet concerned, but we know that it runs in families. So everyone thinks, oh, she's inherited it from her mother, inherited from whoever. But the question is that it is not. It is more epigenetic. What really happens is when the child is in the mother's womb, in utero, if the mother has her hormones, which are very imbalanced, like high androgens or high insulin, that can cause the problem of imprinting of the DNA of that fetus. And when that child is born, if that child is exposed to, very poor lifestyle, is not exercising, not eating, or she's exposed to any changes outside, then she's responsible or she's at risk for developing PCOS. So environment and epigenetic changes in fetal life is known to occur. And can we prevent this problem is the question. Yes, prevention can be done if you see to it that your PCOS patient is in the normal hormonal state before you start her treatment. I'm being honest with you that there are so many women who come with their disorders, with so many problems, and you first correct their hormones. And you won't believe it, we don't even have to go to any treatment. Some of them just get pregnant on their own. Some of them just maximum requires just simple ovulation induction. And there are a few who don't conceive with that, and then we go on to the higher end treatments like IVF. Question is, they must be stimulated to lose weight. They must be advised on what other exercises they must do, what kind of diet they must eat. You have to spend a lot of time with them, and that really helps. So if you look at what really is the primary defect, now I'm not going to go through the whole graph because it might just cause a lot of time to discuss this. But in short, it's an insulin receptor defect. I think it's important for you to understand this. So when there's an insulin receptor defect, whatever a woman eats, the sugar goes up in the blood, the stimulus goes to the pancreas, release more insulin to bring down the sugar. But since there is a receptor defect, that insulin is not recognized by the body that it has come in. And therefore, the signal keeps going to the pancreas, go on releasing more insulin. As that insulin gets into the blood, more and more insulin, it is also, there is a situation where there is it gives rise to, in the liver, it reduces the sex hormone binding globulin. And therefore, the male hormone, which is normally tied up with the sex hormone binding globulin, it it's released free in the blood, and therefore there are free androgens. Similarly, through the ovary, through the through various ways, insulin resistance causes problems at the muscle level also. It causes problem at the adipose level. Adipose tissue, by the way, is now considered as an hormonal organ, which is the largest hormonal or endocrine organ in the body. It produces a lot of insulin, and therefore you have an obese woman, you consider she's insulin resistant. That is what you have to say. Because this visceral obesity, which I'm talking about, see, this is a picture of a subcutaneous fat, which is happening here, which is outside, just under the skin of the patient. Whilst, this is the visceral fat, which is happening within the peritoneal cavity, around the liver. And I'm sure if there are any surgeons, there are surgeons here who open the abdomen, and they see a lot of fat inside the body, lot of fat inside the peritoneal cavity. This is visceral fat. And this is a healthy amount of fat, which you see, which is more subcutaneous. And here you see so much of fat, which causes a lot of insulin resistance and a hormonal imbalance. Now, it could also be that the high androgens are causing the problem. So this is what they say is PCOS can be caused either by high insulin or it can be high androgen. Nobody knows what comes first. So it's a chicken or egg situation, but there are many theories in mind which come in. What we have to remember is if the fetus is exposed to high androgens between different trimesters of pregnancy, then they are subjected to different problems. So depending on what trimester of pregnancy that child is exposed to the male hormone or to the insulin will depend the problem which could occur. And therefore, we have to be very sure that the hormones are in good balance before she plans to get pregnant. So it has been shown that if in the mid part of pregnancy, if a woman puts on much more weight than she should, on an average, a woman after the first trimester puts on about 2 kilos per month. But if she's putting on more than 2 kilos, she's putting on 3 kilos, 4 kilos a month in the mid trimester, these are the patients whose babies will be affected. And therefore, it's important for you to weigh the patient, make sure that she's maintaining her weight and she's not causing harm to the fetus by putting on too much weight. There's enough evidence to show when these babies are born, if the female fetus umbilical cord testosterone is done, it has been shown that the levels of androgens are elevated in the cord blood of those babies. And also they have found that in female babies, when they examine them, the anogenital distance, means from the vulva to the anal region, you'll find that the distance is much more as it is in PCOS women. It's similar in the PCOS girls which are born. So this is what occurs, and this is how we can prevent a problem, and that's why I'm talking about the prevention part. We also know that there could be an unopposed estrogen. If there's too much estrogen, we know there's no ovulation happening. If there's no ovulation, there's no progesterone being released. Estrogen is constantly being released from the ovary. There's no compensatory progesterone. The fat in the body is producing estrogen. So there's so much of estrogen that it causes an imbalance and it causes a problem, and it causes this is where it affects fertility. It reduces endometrial receptivity due to increased progesterone and increased estrogen and low progesterone. And of course, insulin resistance also comes in the way. As I mentioned to you, it affects endometrial receptivity. It reduces fertility because it affects implantation. And all this causes problem. And we have seen that when metformin is given to these patients, they are hyperinsulinemic, it definitely helps them to get better pregnancy rates. Now there's a new theory of gut microbiota. How does a gut affect PCOS? It's shown that if you take a high fat sugar diet in PCOS, there's an increased permeability of the gut. There are gram-negative bacteria produce lipopolysaccharides, which enter circulation, cause a chronic state of low-grade inflammation, activation of the immune system, interferes with insulin receptor, increases the insulin levels, increases the androgens, and causes PCOS. So gut today, there's a lot of research going on gut. And this is something which I thought I must create that awareness that yes, giving them probiotics may help in reducing this problem. Now, coming to the clinical situations, I will give you the background and the basis of what really is happening as of today. So what we must realize is that menstrual dysfunction and polycystic ovaries, as I mentioned, occurs. what we tend to do is that we tend to, even young girls of 14 and 15, we say they've got PCOS, which we should never do, because in short, most of the girls in the first 2-3 years of their periods, they are going to get irregular periods. They are going to get acne. So this is something which we know, and we must make sure that at least after 2 or 3 years, if the problem exists, we should at least say, okay, she's at risk for developing PCOS, but wait till she's completed 8 years of menstruation before you finally label her as a case of PCOS. Of course, keep her under observation, but don't label her unless you're sure. It is found that because of this high androgens, uterine length is found to be shorter in these women. Endometrial thickness is higher, and therefore this is probably because of the high estrogens. In our own data, we looked at about 940 patients of PCOS, and we found that 694 had irregular periods and irregular cycle 73.82%. And the mean age of these women was approximately 28 years. So you can imagine the amount of at least 3/4 of the girls will have irregular periods. So the goals of management in these is really correcting their irregular periods, reducing their acne and hirsutism and alopecia, which is causing them a lot of mental stress, addressing their mental health issues, and preventing obesity by talking to them about weight reduction. Now, all of them may not be obese. 20% of them are lean, but even they require exercises, but they require different type of exercises. They require more of resistance exercises for the muscle, because in the muscle also they'll be able to reduce their insulin resistance. They may be very lean, but if you do their insulin levels, you'll find they're very high. So this is something not all patients, of course, but you will find it. So in short, we have to keep this in mind that even lean PCOS can exist, and we need to look into their hormonal issues. Now, when you come to PCOS and infertility, we know that PCOS is going to cause increased implantation failure, as I've discussed, and you compare it to non-PCOS women, that they find that the pregnancy rates and the live birth rates are much lower, miscarriage rates are higher. So this is something which we have found in PCOS women as compared to non-PCOS. And the reason why this happens is because the endometrium is not, receiving the embryo well, because it is affected by the insulin resistance and all the problems which exist. Though we give progesterone to these patients to get the endometrium in good balance, but there are 30% women who do not respond to the progesterone. They have something called progesterone resistance. Now, this is our own data where we are talking about why it is important for patients now. Not only BMI, we are talking about waist circumference. That is more important than doing only BMI, because with waist circumference, you are able to assess how much is the visceral obesity. If there's visceral obesity, there'll be insulin resistance. And clinically, you can diagnose insulin resistance by the acanthosis nigricans, which you see on the skin tags, etc. And of course, the waist. So here you will find that, there are patients who are in the normal weight group, overweight group, and the obese group. If I'm going to just compare with the normal weight group, if the waist circumference is less than 80 centimeters, we got a pregnancy rate of almost 60%. But this is through assisted reproduction. But if these women who had a waist circumference of more than 80 centimeters, the pregnancy rate dropped to 46%. So same BMI, but different waist circumference. So it's very important that you look for visceral obesity by measuring their waist. Anyone more than 80 centimeters will be suspicious of having insulin resistance and visceral obesity. So this is the point I wanted to bring out, that as the waist circumference is increasing, as the BMI is increasing, the pregnancy rates go down, but only BMI will not give you a correct pattern. You also look at the waist circumference. So the higher the waist circumference, lower is the probability of live birth. Hence, waist circumference, which represents visceral obesity, should be considered as an important marker for lower rates of live birth. So what is the goal of management in an infertile patient? To correct their hormonal balances, reduce their androgens, reduce insulin resistance, and weight reduction. You start with oral inducing ovulation agents. If it doesn't work, you add on IUI. If it doesn't work, then you go to ART. Of course, it depends on the age of the patient. The older the age, we don't wait too long. We try and go straight into a higher technology so that they get the results much faster. When this woman gets pregnant, what happens? If you compare PCOS versus non-PCOS women, PCOS women have a 3 times higher chance of developing diabetes in pregnancy, 3.5 times higher chance of high blood pressure, and 3 times higher chance of losing the baby. And therefore, we know that they have increased risk of pregnancy complications, which increases in Indian women, because Indian ethnicity is known to be at a higher risk of developing diabetes. We see a lot of diabetes in our country, and we see, as an Asian women, 5 times higher in Asian women and compared to American or European women. We at Gynec World have tried to look at the impaired glucose tolerance test, especially in the 3rd trimester. We find that these women who were normal before, by the time they reach 32 to 34 weeks, you'll find that their sugars may go up. And it goes up in quite a bit of, larger percentage of women. It's not only in those. Now, if you compare PCOS women versus general population, the ones who have got PCOS, there's a higher risk of preterm labor. But the ones who are hyperandrogenic PCOS women, they have a 2.25 times higher risk of preterm labor because of the hyperandrogenic status of PCOS. Therefore, again, we must remember that the androgens could be causing preterm labor, and these patients have to be monitored more strictly. What happens to the newborns? The newborns have 2.5 times higher chances of being admitted in the ICU and a 1.5 times higher chance of prematurity. Babies born to PCOS mother are at increased risk of complications at birth and even beyond. What happens to them beyond as they grow up? There's a higher risk of adiposity or fat in these children. The male offspring are found to have increased birth weight, increased resistance, insulin resistance in adulthood, and increased risk of type 2 diabetes. The female offspring have childhood obesity, increased resistance, and an increased newborn head size, which I do not know the reason why. Coming to perimenopause and postmenopause, there is a cluster metabolic syndrome which develops, which includes obesity, hyperinsulinemia, hypertension, atherogenic dyslipidemia, atherosclerosis, and hyperglycemia. And these are all risk factors for cardiovascular disease. So menopause itself increases the risk of metabolic syndrome, and PCOS added to it will be giving a double trouble problem for them. At our own clinic, we find that obese women, 49.3% have insulin resistance, and you will find that if they are overweight, there's a 30% chance of having insulin resistance and a 12% chance of diabetes. So in short, these are the metabolic syndrome association, and therefore these are the women who are at high risk of developing cardiovascular problems. Now, when we looked at the metabolic parameters of the patients who came as a first visit to our clinic, 884 patients analyzed, and we found that if the mean birth age was 28 years, and we found the fasting sugar and the blood sugar post glucose, keeping this definition in mind, we had a 2% risk of already girls at the age of 28 having diabetes. So in short, even young girls are known to have diabetes when they have PCOS. So look for it, don't just ignore it. And somehow HbA1c is not the diagnostic criteria for diabetes. And unless that HbA1c is very high, only then you can say probably diabetic. So in short, they have so many complications. Even when they are 25% were overweight, even when they came to us at the first visit. They also have menstrual dysfunction, heavy menstrual bleeding, and unpredictable patterns because they have got unopposed estrogen exposure to the endometrium. They have no progesterone in circulation. There's increased insulin, increased androgens, and it causes changes in the endometrium, which gives rise to heavy bleeding. We know that endometrial, if it collects if a woman doesn't get her period for 2 months and you do her ultrasound, you will find the endometrium thick. Now that thickness, if you don't relieve, as the months go by, it can turn into endometrial hyperplasia. The woman can get an endometrial polyp, or she can then later on develop endometrial cancer. There are ways to prevent this problem, but the first thing is do the ultrasound on the 4th or 5th day of the period after giving her a progesterone withdrawal, And if the lining is about 5 millimeter or less, there's nothing to worry, but make sure that you keep getting her to get a withdrawal so that she doesn't develop endometrial hyperplasia, which may then lead to cancer. That is very important rather than just leaving her alone or doing just a hysterectomy. It doesn't really necessarily end up with a hysterectomy unless there is evidence of, some serious problem within the uterus. So patients who have got endometrial hyperplasia and cancer, we must make sure that young patients, they want fertility if they've got this problem, and therefore they're not wanting to lose the uterus. You manage them with progesterone. You manage them with, putting in a Mirena if they are not wanting pregnancy at that time, or once they want to get pregnant, give them ovulation-inducing drugs and help them to get pregnant, which will automatically relieve her hyperplasia. So now there are new studies which have shown that when you give metformin to the patient, it has got an anti-tumor effect on the hyperplasia and reduces the chance of getting endometrial cancer because it reduces apoptosis in the endometrial cells. So hence, metformin has been suggested as an adjuvant medication for reversing of endometrial hyperplasia to normal histology. So the goals of management for a 40+ woman is look for risk factors, look for obesity, manage it, tell her to stop smoking because she's at risk for cardiovascular disease, high cholesterol, look for that, look for hypertension, look for impaired glucose tolerance, menstrual dysfunction, endometrial hyperplasia. And all this you would do even in a menopausal woman, but in women with PCOS, you must do it at an earlier age, maybe from the age of 40. So the goals of management would be that an annual checkup for these women is necessary. Do their lipids, do their sugars, fasting post-glucose, blood pressure check, sonography of the uterus, day 4-5 of the cycle to know if there's endometrial thickness, which is normal, and weight and waist measurement, very, very important every year. So prevent their obesity by lifestyle changes like healthy nutrition, exercises. There are plenty, you can talk on that. But I'd like to summarize by saying that the PCOS story as of today, it is that it's a complex and multifactorial disorder affecting many adolescents and around 30% of subfertile couples who are seeking treatment. Endometrial and uterine dysfunction play a pivotal role in PCOS-related infertility, pregnancy, and labor. Metabolic disorders associated with PCOS include hyperandrogenism, hyperinsulinemia, insulin resistance, and are postulated to be involved in disturbances of uterine morphology and function. And women with PCOS present with menstrual dysfunction, which is affecting the uterine health in long term, leading to endometrial hyper and cancer later. So clearly, PCOS is still an unfinished story. And we have recently released this volume 8 of Frontiers in Gynecological Endocrinology, which is an international publication of which I was one of the co-editors, and it's a very good book to read. It's something which will talk about everything related to PCOS. And we are looking forward to our patients awareness programs. This year, last 7 years, we've been focusing on the doctors. This year is going to be our patient awareness sessions, and we've got everything lined up. We'll be starting very soon, and it's going to be through the PCOS Connect, calling it Connected, the Unconnected. Thank you very much for your time. Thank you, and thank you for inviting me.
Correct the patients with PCOS, correct the insulin resistance, and do the ovulation induction, get them pregnant. And then along with progesterone support, we do continue the insulin sensitizers at least for 12 to 14 weeks, maybe longer if required by the blood sugar reports. But is this also to be given in PRP patients? What do you think? In PRP patients, I find very often insulin sensitizers are not continued.
I think it should be depending on how her sugar levels are. Because you don't want her to hypoglycemia. So metformin doesn't reduce her sugars. But in those women, if you monitor them strictly every 6 weeks to 8 weeks, and do their fasting and blood sugar post-glucose, and if you find that they are going over the upper limit, then it's better to stop. Otherwise, you'll end up with hydrangeas, attached baby, and effects already. That's more important, long-term effects. not because of metformin, but because of the uncontrolled.
I think we have 5 minutes if anybody has questions. Thank you. Thank you so much.
Thank you.
Please accept that spot. Dr. Taran, we miss you. We just gave a award, lifetime achievement award to Dr. Sadhna Desai. We wanted to give it together, but I think we were held up, so we took the shot. Thank you very much for accepting our invitation. Dr. Tarang Gyatjadani. Dr. Tarang, she is an orthopedic surgeon and MBA by qualification and a healthcare administrator by passion. Has over 25 years of experience, both national and international, in acute and long-term care operations, as well as the multi-site management in the private and public sector. Dr. Tarang has handled many strategic assignments while working with the Ministry of Health, Changi General Hospital, and Alexandra Hospital during her 14 years of tenure at Singapore. She has been felicitated with numerous awards, the most recent being the Governor of Maharashtra, wherein she was conferred the Healthcare Leader of the Year award. She was also recognized as healthcare. She was also recognized as a Healthcare Leader of the Year 2022 by Financial Express Summit held recently at Delhi. Other awards in the past include the Best CEO of the Year several times over, Rashtriya Vibhushan Award in 2016, and Rashtriya Ratan Award in 2015. Dr. Tarang believes in the importance of developing sustainable healthcare systems with a prime focus on quality patient care. This has been ably demonstrated by the outstanding management of Reliance Hospital during the recent COVID pandemic. She strongly believes in futuristic healthcare technology, skilled clinicians, and patient experience will provide India with the state-of-art hospitals in future. On a personal note, I would like to thank her on behalf of CWARD Medical Association for her support to our CME programs and conferences ever since she has been CEO at Reliance Hospital. I would also thank her because whenever we have approached her, she has never said no. Like my departmental head, Dr. Ashad Dalal, she never says no to me also. So thank you very much. And I think we have all experienced recently during the COVID care that you have gone all out for all the staff and the doctors and keep us safe from COVID. Thank you very much. So on behalf of the CWARD Medical Association, we would like to present an Excellence Award to Dr. Tarang Gyatjadani in recognition of her exemplary service and outstanding contribution in the field of medical care and management, especially towards the upliftment of community health. We would also like to present her a small present from CWARD Medical Association, specially designed for you by my wife.
Thank you so much. Thank you. Thank you. Very good morning to all, and I think I have the opportunity to get this award with Madam
I was really caught up with some of our patients here who I had promised I would have them on Sunday. So my apologies. But I hope that you will have a great session today. And I'm sure Dr. Firoza will also talk about it, but I just wanted to share that this forum is very, very important and comes very kindly because we are about to launch something in the field of women health along the vision of our chairperson, Ms. Deepika Mani soon. So it will be an attempt to integrate all what is required for the well-being of the women. I leave it at this for the time, but very soon I'm sure you will see that how we are going to have that entire piece launched. And it has to be nothing except the perfect. It can't be anything less than the best in the world because the entire piece, every point is self-woven by none other than the most powerful lady I know on this earth, which is our chairperson, Mrs. Deepika Mani, and it has been technically put in place with every small area to be considered with the best. There's nothing but the best by Dr. Firoza. So I'm sure it will be magic and it will be something which every woman will bless the coming years to all of us. And we would really look forward to integrating all of you with us on that in some way or the other to give the best to all the women, whether it's a 14-year-old teenager or a 70-year-old lady. So I think that's where the vision is, and that's what we will work together with all of you. And once again, thank you so much, Dr. Kamar, and everyone involved. And I personally feel that community medicine is a very, very important part of healthcare delivery system. I have had 14 years of experience of Singapore, and I think the primary healthcare was always the most important part of our healthcare delivery in Singapore, because I think it's to the community that the whole preventive, the whole treatment, and the whole palliative medicine starts from. The hospitals should only be places where patients should come for acute care. And as an institute, we would want to stand ourselves from prevention to palliative, and we can't do anything, we can't take a single step without integrating the community medicine and all of you in the community. So once again, thank you so much for considering me worthy for this recognition, and thanks a lot. Keep on doing the great work that you all are doing. All the very best to you. Stay well. Thank you.
Thank you very much for being here and encouraging us. Thank you. We go on to the next speaker.
For the next session on overcoming infertility with Dr. Firoza Parekh, I would like to call upon the chairpersons, Dr. Sadhana Desai ma'am. Ma'am requires no introduction with her decades of experience, recipient of Neonatal Award, including the Lifetime Achievement Award from Indian Infertility Society and the FIGO Award. I would also like to call upon Dr. Prema Kanya ma'am. Madam has an experience of 30 years in the field with a specialization in endometriosis, fertility, and hydroscopy.
I call upon Dr. Firoza Parekh, very clear for study of mine. He is doing excellent work in field of research. She doesn't require much introduction, but she has a state of art and just local. And she has been past president of
going to talk to us on her experience in infertility. I won't say lifetime experience because I think you have a long life. Then you are going to have many more experiences in infertility and reality. So I think it is best that you learn about your experience so far.
Dear friends, I stand in the shadow of Dr. Sadhana Desai, who has been an inspiration, an icon, a wonderful teacher, and a dear friend, and someone you can always, she's a go-to person. You have a difficulty, you can go to her. Dr. Taran Gyanchandani, Dr. Kanya, Dr. Anil, Nozer, my dear Guru, dear Rekha, and so many of my friends, seniors, and colleagues. Joy has done a superb job. Thank you, Kamlesh, for this invitation. I stand here before you to share some of the very intimate moments of some part of my personal life and some part of my professional life. And all this would not be possible. And if I fail to mention my mentors, Dr. B.N. Chakrabarti, Sadhana Desai, Dr. Hansotia, Dr. Alan Dichoni, Dr. Many, and I won't continue with the list, but I'm grateful to everyone for this opportunity. Now, before I start, as Dr. Gyanchandani said, I want to introduce the concept of Well Women Center. It was Mrs. Nitambani's dream not only to install a state-of-the-art IVF clinic, but put forward women's needs. And women's needs don't start in the reproductive years, they start it is a transgeneration epigenetic effect. So it starts even before the baby is born, even when the baby is in the mother's womb. And it goes all the way from birth to her postmenopausal years. And it is our endeavor here to offer women the best of the best, so that, as everybody says, we just want to pursue and persist a way by helping every woman in every field, whether she has PCOS, whether she's an adolescent, whether it is menopause, whether she's a cancer-affected patient. And a very big part of our vision and Mrs. Ambani's vision is to help those afflicted with cancer, both males and females, and offer fertility protection. So with these few words, I'd like to go on with my talk. And I'll start way back when I was at Yale, when I was a fellow there, and we were at that point doing micromanipulation on mice eggs. And I was invited to Jaslok, where I started my career. Here, we translated the entire laboratory, which was at Yale, to what was at Jaslok. And at that point in time, it was just the first year of starting the department, and we had a visitor from Australia. He was an embryologist, a famous embryologist. When he came to the lab, he saw all the equipment, and the equipment included micromanipulation tools, which we actually would grind the pipettes, the micropipettes, because at that point, commercial micropipettes were not available. And he looked at me and he laughed. He actually laughed. And he said that, you think that sitting in India, you will be able to do micromanipulation? Why have you invested all this money? So I laughed back at him. And I said, Doctor so-and-so, we will have a baby much before you in Australia will. And that was the beginning of ICSI. The first ICSI baby was born by serendipity. And this is Professor André van Stratteghem in Belgium. He is the father of ICSI. And ICSI revolutionized the world of IVF. Before that, men who had very low sperm counts, no sperm counts, had no option but to go for adoption or to consider doing IVF and failing, or doing with donor sperm. So Palermo was a young man at that time with André van Stratteghem, and he was practicing putting sperm in the outer layer, that is the subzonal layer of the egg. By chance, one sperm missed that space and went into the cytoplasm. He was very scared because he thought now this egg is destroyed, because he had touched the heart of the cytoplasm. He kept that egg aside because he said that tomorrow I have to see how badly it is damaged. And every egg is very precious. But lo and behold, of those cohort of eggs, what really fertilized was that one egg where the sperm has entered the cytoplasm. So luck, chance, opportunity, everything has to be present when you do an experiment. No experiment, even if it fails, is futile. No transfer of embryos is ever futile, even when it's a failure, because it teaches you a lot. So we are all grateful to people like Dr. Palermo, who set the trend. And the first ICSI baby in the world was born in 1992. And our ICSI baby of Southeast Asia, Love Singh, who is now a fantastic man, he's a lawyer, we are in touch with him. He was born in 1994. Very soon, many clinics, Dr. Durusha, Madam Sadhna Desai, everybody started getting their pregnancies, not because of anything, because of their diligence, because of their hard work. So what are the difficulties that we face when we are treating infertile couples? The low implantation rates. There is a chemical crosstalk between the egg and the uterine environment. And this is one of the reasons why implantation doesn't work. There are literally 200 steps to implantation. Once I was walking with my husband Rajesh on Marine Drive, and we were talking about the work of my PhD student, Dhananjay, who is now in our team here. And we talked about the waste that happens in the IVF lab, where we waste so many disposables, so many things. And, you know, it becomes a culture of waste. So Rajesh suggested for his PhD topic, why don't you look at the cumulus cells, which you are anyway discarding? When we look at the egg, we take out the cumulus cells, which are the protective cover of the egg, and work on it and see what is the treasure over there. We did that. And what we did is we cultured the egg with the cumulus cells. And here you can see the cluster of cumulus cells where there is a chemical crosstalk in the first picture in A. And away from the petri dish, there is no communication between the embryo and the oocyte. And we saw that there is an actual communication. If you look at the picture on the right, here you will see that is one single dendritic process, which is going from the embryo towards the cumulus cell as if they are talking. It's like a telephone wire. And this establishes that all the crosstalk occurs between the cumulus cells. Today, there are studies on mRNAs which show that the transcriptome of the cumulus cells reflect on the embryo and its ability to implant. So this got published in Fertility Sterility way back in 2006, and we practice this even today, particularly in women have less number of eggs. There is a marriage between genetics and IVF, and all of us who practice IVF are faced with patients who are otherwise fertile, but have multiple miscarriages, they have certain genetic issues. And then here, what we did, we started the PGD lab in 2000. And at that point in time, we got several patients coming to us for translocations. You know, there are translocations like Robertsonian translocations, reciprocal translocations. Then we had other things where we did a lot of work, and here we were a couple much later where we started offering PGT for monogenic disorders. This is a couple where the lady had BRCA1 and 2 mutations. Her whole family was loaded with history for ovarian cancer, prostatic cancer, colonic cancer, breast cancer, and she herself carried the genes. We identified by PGT the embryos that were free of the mutation, and then she had a set of twins. So this is the marriage of genetics with IVF. As a point to note over here, at our lab at the Reliance Foundation Hospital, we have included every single equipment, every single witnessing system, everything that is going to enhance our rates. And once we launch, I will urge you all to visit us to see the state of the art that we have set up so that we can give the best experience to women of all ages. We also recently reported, not very recently, about 4 years ago, where we did PGT-M for a couple with thalassemia mutations. They already had a child affected by thalassemia major. And as you know, thalassemia major for one child will cost about 90 lakhs to 1 crore of treatment over the short lifespan. What we did the PGT-M, where we eliminated all embryos which were aneuploid, which had the gene of mutation, and we did the haplotyping matching with the embryo and the older sibling. Out of so many embryos we created, 18 blastocysts, we only got one embryo that matched. And luckily, she conceived. Today, the baby has had a bone marrow transplant and no more blood transfusions. So it may appear that this is a very expensive technology. It's not expensive. Look at the cost. look at the cost, the burden of disease for the child. We have eliminated the burden of disease, and that is something which improves the quality of life. A very major concern which all of us in our practice are facing, I'm sure all of you see this, young women in the 25s to 35s are facing early ovarian senescence. What we did a study, and we did it with Metropolis Lab Guru, where they helped us to analyze 50,000 samples of infertile women who were coming to all over India, pan-India, looking at their AMH. That formed the group A. And then we had a group B, which was fertile women who already had children. And then there was a group C, which were women who were Caucasian, and we looked at their AMH. And just concentrate on this slide. Here it shows that women in group A, less than 30 years, 30 to 34 years, 35 to 39 years, all had AMHs less than 2. And look at the percentages, how it is climbing. We also showed that women in group B, who were so-called fertile, when matched, and when we looked at the Caucasian women, there was a decrease in their AMH, significant decrease. We also saw that there was a decrease in the median AMH between group A and group B. So Indian women are facing early ovarian senescence. There's a very nice paper which shows that Indian women age 6 years before Caucasian women. And this should make us very alarmed, because we are now dealing with a population of young women who are perimenopausal, premenopausal, and we face this all the time. We don't know how to treat these women because they have such low AMH. There's one way, and I'm sure all IVF experts here use this. We use what is known as platelet-rich plasma, how people use it for the skin, for wrinkles, for hair. And we did a study which we published in Global Reproductive Health, where we showed that when we took 2 sets of patients, those who underwent IOPRP and those who did not, there was a significant increase in the pregnancy rates. The pregnancy rates went from 46% of those women who had IOPRP, and in the control group, it was 25%. So why I'm sharing these experiences with you is to inform you that yes, infertility is a problem, not only in India, it's a global problem, but there are ways and means to elevate these problems. In our country, genital tuberculosis, as you know, is a possibacillary disease, and sometimes we miss it. Sometimes we overdiagnose it. We do not know sometimes whether to treat a patient or not. It is a real dilemma, particularly when we are treating women with suspected female genital TB. And sometimes we may get a negative TB PCR, we may get a negative gene explorer, we may get a negative culture. So we did a molecular study where we looked at inflammatory pathways. We looked at the upregulation of 271 genes which got upregulated, and 61 genes which were in the endometrium which got downregulated. And this was significant in women who had TB. So in case there is a difficult patient where you cannot for sure say that should I treat her, should I not treat her, this test for inflammatory pathways is very helpful to go ahead and say yes with determination that you can treat this woman. This is a paper which we recently published in the American Journal of Reproductive Immunology, and we got many citations for this paper. Now, in the COVID times, we were doing some work on chemicals which are present in the follicular fluid of women, particularly bisphenol and the phthalates and metabolites of phthalates. And we wanted to see what happened during the COVID lockdown. Because we were not doing IVF then, we looked at these women who are now undergoing IVF later on. And we looked at 6 metabolites, the primary and the secondary metabolites of phthalates. And when we did this, we compared those who had done IVF and their follicular fluids pre-COVID and post-COVID. There are certain chemicals that we saw which were decreased in women in the post-COVID area, and those are related to women using lipstick, shampoo, nail polish. So this is known as the nail polish effect or the lipstick effect. There's a particular thing called the lipstick effect, where in the past, in the times of the depression, people saw this effect in place. So what we saw during COVID times is those metabolites which are present in masks increased, and those metabolites that were present in nail polish, shampoo, hair coloring decreased, because now women were not going to work. So obviously they were not using chemicals on their body. So this paper was also published in Fertility and Sterility recently. In our center here, we are going to plan fertility protection for both males and females. We already had a wonderful workshop with Dr. Klaus Anderson about 3 months ago, where and now he's going to be coming soon, where we will be looking at saving the ovarian tissue of women, either for cancer or for protection for women who are undergoing an early menopause, as I showed in my previous slide. This looks like a complex procedure. It's not very complex. It requires a synchrony between the lab, the laparoscopic surgeon, the IVF lab. And this is one slide which I want all of you to look at very carefully, because just as Indian women are seeing a decline in their fertility, a global phenomenon shows that men over these years are showing a fall in their sperm counts. Look at this. There is a study by Shauna Swan, which has been published, and she's made it into a book, where she has shown that from 1973 to today, there is a steep decline in the sperm count. And we did a study where we looked at the sperm counts at our center and over 10 years. What we saw is that those men who had male factor, and that therefore they had poor count, poor motility, poor morphology, their percentage increased over the years. And even the non-male factor group, what we saw is those men who had normal parameters, their percentage decreased. So yes, it did affect the sperm parameters in males with male factor and non-male factor. And this is just to show the percentage increasing of poor sperm in the male factor group and good sperm decreasing, the percentage decreasing in those with a non-male factor group. And what are the worries? What is it that is contributing to this phenomenon? We are seeing a fall in the testosterone worldwide. We are seeing that there can be epigenetic implications. That means that what we are doing today to the world will not only affect the woman, but it will be transgeneration. It will affect generations after generations. Lifestyle chemicals are something that we need to urge patients to change their lifestyle and for us to change our lifestyle. I end this with a simple slide, and all of you will bear this with me, that there is no IVF, there's no I in IVF. It is only we. If we succeed, if we set up something, it is because we are together, because we are a team, because we appreciate people who help us. And of course, we are always thankful to all our patients who make us what we are. Thank you for your listening. Thank you for being here. God bless.
Some of your into your experience. Thank you. There is so much good research work in the formulation. Clinicians are only clinicians who do doctor research. There are very few who also do clinical work as well as research. I think this is excellent. What is your opinion about the stem cell research in the stem cells now have been there for years and years. In fact, you may remember that we set up the Reliance Hospital and we created, we were 10 people who created the stem cells, embryonic cells. 10 cells. Now, 15 people in stem cells. So, of course, what it was say 20 years ago and what it is now. But I think stem cells, if harnessed well, will be not only for IVF, but there is a plethora of diseases that we use. The more important thing today is what is known as even in stem cells, so and pharmacoeconomic dynamics. If you initiate something on this with HN or IRR or individuals on extracellular components, extracellular That is the future of health. Thank you very much.
Thank you.
Thank you very much for your.
Excuse me.
Thank you, ma'am, for the very enriching session. Managing from your own. It's like this, huh? It's like this. It is like this. It is. Focus on them. If I want you to put them over there, and then under there it is. Yeah. Yeah.
Please have the camera switching that way.
Next session is a panel discussion on who is our director in the Department of Obstetrics and Gynaecology at Reliance Hospital, and Dr. Arnav.
On behalf of Dr. Dalal and myself, I'd like to thank the CWAD Medical Association for inviting us, and especially Dr. Vijay Khambati, and giving us this very catchy topic as sugar and spice and things not so nice. All the speakers this morning have told us the nice way to overcome challenges, but as physicians, every patient is a puzzle. And so to put it scientifically, what we are going to talk about with our learned panelists is about endocrine dilemmas in OBGYN. As it is said, to control your hormones is to control your life. And for this reason, I think probably the endocrine disorders affect not only human reproduction, but I think a woman's life totally. And so we'll be looking at various phases of a woman's life and how the hormones are affecting her and how we should do our best to normalize the imbalances. So this afternoon we have three panelists, Dr. Durusha, ma'am, could we have you? Dr. Rekha Davar, Dr. Pankaj Parekh, Dr. Prema Kanya, Dr. Gaurav Beswal, our endocrinologist colleague, Dr. Nitin Saidungar, and Dr. Priyanka Lullar. So we'll start with the first case.
Everybody on that side. Yeah, you can take. Rema. Okay. Move it. Yes, ma'am.
Anyway. What's your room?
Chair will be. That is because you are live on YouTube. So smile. All right. So we start with our first case. 32 years old, diagnosed with GDF. She's only on diet and exercise since 28 weeks. Blood and urine sugars are very well controlled. She presents now at 37 weeks and she has some concerns about her fetal well-being. NST and Doppler are both normal. Now, what would you consider at this time when she comes? She's 37 weeks, she's a gestational diabetes, she's only controlled with a diet and exercise. Parameters are almost normal. Yes, though, she's 37 weeks, not a problem. Leave her alone for some time. Right, so she's 37 with no risk factor, so you would not consider admitting her, you would not consider. What test would you ask her to do, if any, and how long?
So I would keep a check on her sugars for sure. I would like to do her PTT count. I would ask her to start preparing at 34 weeks. I would ask her to do a color Doppler, which would be probably on a weekly basis along with the NST, and check when she is likely to be useful. If she's around 38 or 39 weeks and she's not yet delivered, then I would like to induce her at 35 weeks.
Anything, any change or anything else?
Yes, maybe in the monitoring the blood pressure as well.
Right, so I think there is a consensus that in such a patient who's only on diet and managed with exercise, you would continue till at least 39 weeks. Now the same woman, she is treated with insulin for her gestational diabetes. She has also come at 37 weeks. Now what do we do? If she is a gestational diabetic on insulin, would you consider now what would be the period of gestation you would like to wait till, and how would you like to manage this leave?
So at 38 weeks, probably I'd assess her for inducibility and favorable induce, otherwise go for a planned cesarean.
I would like to see the fetal weight and the fetal well-being. I would like to see the fetal weight, fetal well-being, whether it is a latch or
not a change. She's 37 weeks. She's on insulin.
Yeah, madam.
Her NST is normal.
But if the fetal weight is 4 kilos, then there is expected fetal weight.
Yes. Okay. So you would like to see the expected fetal weight.
I would like to see that. I would see the liker and then take a call on induction or earlier induction or weight. Expected management.
Okay. So Anybody over here would say direct cesarean for a gestational diabetic on insulin? Yes, Dr. Dawar? So I think
Close monitoring.
I think the consensus is that if you are not on anything, there's no reason for you not to continue till term, that is 39-40 weeks, where let us go into spontaneous labor or induction, if at all considered, would be at that time. Surveillance is indicated in both. Now, earlier delivery is only poorly controlled. Dr. Beswat, we would just like to add one thing. Most people, gestational diabetics who come, you are not only giving them insulin and all. There are many other things that you are giving. What are those? And in pregnancy, how early will you start?
So most women will be on metformin also along with, and acarbose is also a decent drug, which is not used very often, but it is quite helpful. And category-wise, both are category B in terms of risk. So it's a good drug to use. In terms of, if I want the question back, if the woman is approaching labor, I would want to stop metformin at least 24 hours before, in case she goes for a major surgery, like LSES, or if there's a major blood loss. We want to avoid things like lactic acidosis due to hypoxia. We would want to monitor the sugars more closely, because the lady will not be eating very well. She may be on prolonged fasting. We want to either withdraw or taper down the long-acting insulin and just keep her on short-acting. So that is how we should approach the time around delivery.
Thank you. Priyanka, you tell me, what is your advice for these women? Prema just expressed her concern that the baby can be more. If diabetes, the fetal concerns will come to later, but when she has come and we say you go to a dietitian.
Yeah.
So what is the basic diet that we would like to?
So we would look at a balanced diet. Everything works in balance. We would look at the carbohydrates. Those should be low glycemic carbohydrates, the high fibrous ones, the millets, bajra, ragi. Those is what we look at. We look at proteins, good quality protein, lean meats, dairy products is what we look at. Then fruits and vegetables, which would provide the vitamins and minerals, many bioactives also, cinnamon, green tea, those things will also help in controlling it. Those are just add-ons. Without a balanced diet, those wouldn't work. Healthy fats, good amount of omega-3 fatty acids would also play a role in good fetal health. And good hydration. So it all works as a balance. But carbohydrate is the main concern that we would look at over here.
What I meant to say is, very people have just this idea that if you're a diabetic, avoid sugar. That going to a dietitian for an advice goes beyond not eating sugar. It means eating healthy and getting your required, whatever requirements.
All the nutrients.
Prema, you said about fetal weight. What are the fetal concerns in any patient who is a diabetic? She comes with a GB, and what are your fetal concerns?
Fetal concerns, one will be in poorly controlled diabetics, it might be low. In fact, there will be intrauterine growth retardation sometimes, or sometimes very, very large for the baby. In the sense, there will be fetal edema, large baby, and there will be excessive fluid around the baby. Or if there is IUGR, growth retardation, it will be associated with low amounts of fluids also. And so fetal compromise, placental blood flow, we will have to see everything.
So this patient has come to you not in 37 weeks, but she's come with a very poor control and she's just pregnant. She comes to you saying that I want a termination because my blood sugar levels are 300 fasting, 450 post lunch. So if that is the thing, her glycosylated hemoglobin is 8.7. Anyone, do you think that you would agree with this patient and terminate her because the sugar is 350 when she has come to you? She's 6 weeks.
I would terminate the pregnancy.
because it's a well-known fact that the chances of congenital defects in the baby are 8 times higher in the first trimester if the sugars are not controlled. And that is the advice to be given to all women who are planning pregnancy for preconceptional counseling. They must do all their investigations before they plan a pregnancy. And this is what I tell women, that don't just get pregnant and then come to us. Come before you get pregnant. What all you need to do, take your folic acid, get your sugars under control, do your thyroid test, do everything possible to make sure you're fine before getting pregnant.
And suppose she wants to continue?
She wants to continue, of course, you will immediately refer her to our friends who will control her sugars very well. And
anyway, we will refer to our friends whether she wants to finish or she wants to continue. The question is besides the
no, to control her sugars, she need immediate control. And therefore, she requires insulin therapy and she will require continuous monitoring, which I'm not an expert at. It's the endocrinologist. And therefore, I would refer.
Yeah.
So that is one thing, because I do not want harm to that baby.
Yeah, and the second thing is what she has to very clearly understand, that she is uncontrolled, so you have to talk to her about.
We have to counsel her about her problems, whatever are the difficulties she may face as the pregnancy goes along, and counsel her that when she's pregnant, she has to keep her sugars under control, monitor sugars, eat well, see the dietitian, etc., and have a regular follow-up.
I would like to share a story about the patient in this hospital. First time she came as an incomplete abortion, and routine blood test 300, 400 HbA1c. She was not aware, young bride. So we did abortion. After that, she came for one follow-up and never turned up. After a year, she came back again with 2 months amenorrhea pregnancy. We did the blood test, same story, 300, 400. We explained to her, but she said, no, I'm going to take a risk. Most important is to tell them about the fetal malformation which had already occurred. First 8 weeks are only important when the systems are being played out. And we did continue, and she had anenchyfalin. I had to do a second trimester.
So, Dr. Davar, what do you, according to you, when should we test for diabetes? What are the tests you recommend?
So, for diabetes means blood sugar should be done before pregnancy. In this case,
no, she's come to you pregnant. Now she's 6 weeks now. As a routine, any antenatal protocol, when do you want to do your blood sugar test? What sugar test will you do and how many times?
The first registration, whenever she comes and first time registers, I will do a fasting, and second repeat at 16 to 18 weeks.
Yes, anybody, Duru, would you like to?
Depending on the risk factors, I would not only do a fasting, but a post 75 grams glucose. I don't know whether Gaurav will agree with me, but many a times when we ask a PP, patients are smart.
So I think that's very important that no PP row, you give the 75 grams.
I think Dr. Durusha also mentioned in her talk.
She's vigorously nodding, so she's fully agreeing with you. So Duru, no. Would you agree that you need to do it a little later, or you would do at 16 and stop it then?
No. Number one, preconception. Number two, in during first trimester. Number three, in mid trimester. Number four, and of course, books don't mention that. They say 32 to 34. But my advice is to do it because I do it for every woman, and I find there are some women, especially the PCOS women, who develop this impaired glucose tolerance even in the 4th month or the 5th month. So I like to do it preconception, first trimester, second trimester, third trimester, 28 to 30
don't tell me second trimester, third. Okay, mention the weeks. Okay, right, because first trimester 6 weeks and a 23-year-old girl with no history. Would you still say that you want to do it at the first visit, or would you tell her do it at 10 weeks after the fetal heart is established?
I would do it right away whenever she comes to us.
Okay, so that is the first time that whenever a woman comes in the first visit, you do the thing. Then when would you like to repeat?
The fasting and the 75 weeks. The second one I do is at about 16 weeks or so. The third one I do at about 27, 28 weeks, and the fourth one at about 32 to 34 weeks.
Okay, and all the times you would do with the 75 grams?
Absolutely.
Anybody on the panel would have a different opinion?
Gaurav, universal screening or selective screening?
Yeah, I don't have a different opinion, but what I would add is an HbA1c. Now, the only difference between the guidelines and the current scenario is kind of moving faster than the guidelines. And women are getting pregnant at older and older ages. And what we've noticed is diabetes, it comes earlier on in successful generations. So the father got it at the age of 60 because of obesity and number of things. The number of women I see, I mean, we are using the term GDM, which technically means that the diabetes has been induced because of pregnancy around 24 to 28 weeks. That's the classical definition. But a lot of times we are seeing pre-existing type 2 diabetes or pre-diabetes in pregnancy, which will go on to develop. So I think we need to be equipped for that. The way I see it, HbA1c is a good test to do for before pregnancy, and women with hypothyroidism, I'm sure we come to that. But we should counsel them as soon as they find out that they are pregnant. If I see a 18-year-old girl, I need to tell them right away that look, when you get pregnant, when you get married, please make sure that you are testing yourself. Don't get pregnant before making sure you have.
So I agree. There are many people who, in an 18, 19-year-old, no risk to do a random and a HbA1c to start with, and then with 75 grams and HbA1c in all the trimesters. Definitely.
I'd like to ask a question to Dr. At what HbA1c do you get a diagnosis of gestational diabetes?
So the definition of diabetes remains at 6.5. However,
no, I don't think so, because HbA1c takes 3 months.
Yeah.
We are not making a gestational diabetes on this. That is why in the first trimester, when you have either done the random or the fasting 75 grams and HbA1c, then you can say that her HbA1c is 5.9 or 6. Anyway, she is borderline. Yes. But if her HbA1c is 4.2, the HbA1c is not going to become 7 if she has 200 sugar. So we are agreeing with.
Absolutely. HbA1c should not be used as the sole criteria because there's anemia, there's the fever dilution.
Absolutely.
It could be an add-on test, but I think the GPTV should be the firm.
So I think the message is very, very clear of what you need to do and in which trimesters. Dr. Parekh, lastly to you, we have now delivered or she is on an insulin or she is on metformin with something. We have been careful. We have finished 37 completed weeks. End of around 38 weeks we have delivered. What are your neonatal concerns as far as this baby or any other baby born to a diabetic mother?
Actually, as a pediatrician and neonatologist, we really do not care whether you give insulin or a metformin. What we are interested in is a glycemic control. If the glycemic control is not proper in early pregnancy, then as Dr. Rekha said, you deliver a baby with multiple congenital malformation. It can be renal, like duplication or renal agenesis. It can be CNS, like anencephaly, spina bifida, caudal dysplasia, or it can be even congenital heart, including VSD and TGA, transposition of great arteries. So that is one thing which is very important to have a proper glycemic control. If there is improper glycemic control in a late pregnancy, you are worried about large babies. We are worried about RDS. We are worried about hypoglycemia. We are worried about polycythemia. Now it is, these babies, first thing what we look at are two things. Number one is whether the baby's glucose is normal or not. Because hypoglycemia can manifest within 30 minutes of birth. So we do immediately at birth, then 30 minutes, 1 hour, 2 hours, 4 hours, 8 hours, 12 hours, and 30 hours. And in between if required. So there is one thing which the glucose control is. Another thing which is important to us, babies born like this, is respiratory distress. There are 3 ways we are worried about respiratory distress. One is genuine RDS, respiratory distress syndrome. Most of these babies, being a large babies, are delivered cesarean. So we are worried about TTN also. It's not to be worried, but to be taken care of. There are three things which causes breathlessness in a baby born of a gestational diabetic mother. One is RDS, second is TTN, and third is persistent pulmonary hypertension because of polycythemia. So these babies needs a lot of observation about after once a good clinical examination to find out gross congenital anomaly. Two things important: looking a watch on the respiratory system and measuring a glucose level.
So how long? The baby has apparently not got any problem, but how long do you need to observe these babies after birth before saying now they are safe?
Usually, the hypoglycemia, if it has to manifest, it manifests in first 30 hours. Usually, when the first reading, 30 minutes reading, 1, 2, and 4 hours readings are maintained, then we are not much worried about hypoglycemia. Respiratory distress syndrome can start in first 24 hours. TTN can start in first 48 to 72 hours. By persistent pulmonary hypertension because of polycythemia can give you trouble for a long time. So these children need to be observed. Glucose part we are less worried about than what we are worried about respiratory distress. So once, and polycythemia is not very difficult to diagnose. Appearance of the baby and one PC. Once you have hematocrit.
You routinely do a P.
No, we don't do hematocrit. Because if the child is not distressed, clinically not looking extraordinarily pink, active, sucking milk very well, I think we don't need to do anything except glucose.
Oh, thank you. Now we'll move on to the next case.
Yeah. So we move on to a younger girl, 15-year-old, overweight student. She's being teased for acne and visible hair on her face. Menarche was at 13 years. Her periods are irregular. Her biochemical investigations revealed a serum testosterone of 450 and a 17-hydroxyprogesterone of 1.9. I'd like to ask the endocrinologist, how do you interpret these, and would you like to go beyond these in her evaluation?
So in any adolescent with acne and hirsutism and ovulatory dysfunction or oligomenorrhea. Sorry, can I go back to the question? I missed whether she has oligomenorrhea. Yeah. So one of the primary diagnosis is PCOS. However, we should remember that the diagnostic criteria of PCOS in adolescent and adults, they do differ. Because in adults, these criteria are very clear-cut. But in adolescents, these things are blurred by the ranges of normality. Because you do have acne in adolescents, you do have certain amount of hirsutism as a part of hormonal changes. So it needs to, so we often use the term at risk of PCOS and we do not label them right away as PCOS. It's also important to rule out other causes of hyperandrogenism.
Yeah, so just on these two values of testosterone and hydroxyprogesterone, when do you think that, okay, things are PCOS-like or things are beyond the ovary?
So this looks more like PCOS, right? Because the serum testosterone is on the higher side. So the 17-OH is quite okay.
What would be the cutoffs that we should keep as red flags?
So in the 17-OH peak, if you have values of 8 and above, so we would want to do a challenge, and we would be looking out for non-classical congenital hyperplasia, NCCH. So that is one of the important differentials, especially in an adolescent.
Okay, and testosterone, should we go in for total testosterone, free testosterone? What is significant? What should be the ideal test?
So the first test should be a total testosterone, but if it is raised, then we can do a SHBG and a free testosterone.
A value of 200 would be absolutely okay. A value of 400 would be that there is some androgenic phenomenon. A value of say 800 would say that she requires more.
200 is quite okay, but anything more than 400, we need to investigate more. 800 is yes, obviously on the higher side.
I think a quick rule of thumb is the rule of 200, 200, 400, and 800.
Would you suggest DHES to be done or just testosterone?
Generally, I do include DHES, 17-OHP, Prolactin, thyroid. So it's part of the PCOS panel. the guidelines they do, guidelines are made with a different viewpoint of economics as well, which does not always apply to our setups. It depends upon what setup we are working in. But I think by and large, we would do all these tests.
The next question is to Dr. Durusha. Ma'am, this young girl, perception of body image, she's being teased at school. So what really is clinically significant hirsutism according to you?
Clinically significant hirsutism is supposed to be measured by the Fairman-Golby score, which should be more than 8. And that is how it's calculated is that you look for thick hair, which is like male type of hair, in different parts of the body, different sites. And usually there is a score from 0 to 4. And the total score comes to 36. If it is more than 8 on 36, then we would say it is positive FG score for hirsutism. Now those sites are usually the upper lip, the chin, the beard area, midline of the chest, around the nipples, lower part of the abdomen, intraumbilical. Those are the sites which you are really going to look for these thickish hair. Now the trouble is to be when girls come to us, it's very difficult to know whether the score is FG8 or not, because most of them have already waxed or threaded or lasered everything and come. So in short, you may not be able to see clinical hyperandrogenism in these women or in these girls. So what the literature says is that you should see at least 1 centimeter of thick hair when you can see. Now which girl is going to walk around with 1 centimeter of thick hair on her upper lip or chin? She's not going to do it. So you'll never diagnose it unless you look carefully. If you look carefully, you'll find those little black spots on the stubs of those hair. Because even though they've lasered them or waxed them, unless they've done it just 1 day before coming to see you, you will notice those very, those blackish dots, very typical. And that is something which will help you to score. The other thing which helps me, of course, we must remember that different ethnicities have a different cutoff. So in Indian ethnicity, we have 8 as a cutoff. But if you see the East Asian population, the Chinese or the Japanese, even though the score is 4, they would say it's hirsutism because they are not so, they don't have so much of thick hair as Indians do. South Asians have more problems, and therefore we have to remember that. So ethnicity is important. Clinical hyperandrogenism depending on what has been pursued, but how I monitor the patients is I ask them how often do you wax or how often do you thread? Because when I'm putting on therapy, how do I know whether she's getting better? Unless I do the androgen levels every time. So in short, if they say, okay, I do it every alternate day, I shave every alternate day, and then the therapy is started, and then gradually you'll find they're shaving much less as the days go by. Similarly, whatever is the procedure they are using for removing the hair, if that procedure is really helping, and the medication you're giving is helping her, then you'll find that the interval between the different methodologies increases. So that is a good way of assessing.
Okay, thank you so much, ma'am.
One thing about this guru, they concentrate on facial hairs and they come with facials and all done. But you look at the breast, the straight, thick hairs and midline abdomen. They are there. They usually don't remove.
They are waxing their whole body now. Yes. Even women who don't have hirsutism are waxing. The young girls who are wearing the cholis and going for weddings, laser the whole body.
Okay. So, Gaurav, you talked about the other differentials, and I think these would be some of the differentials that would go beyond the ovary, and obviously then you would have an adrenal-centric approach, something to add on with imaging like CT, MR, or more adrenal profile, specific markers, etc. I'd like to move on to Davar ma'am. Davar ma'am, you always emphasize on counseling. So how would you counsel the child, that is the 15-year-old girl, and her mother? Because she has a serious issue in school, in college, because she feels that, she just can't adjust to whatever people are saying.
No, so first the child we have to consider, she is the one who is more worried about her body image, and diet and exercise is going to help her to normalize even her hormones and the body image. So that is very important, diet, because today most of the children, they like the food which is not good for them. Our mothers served us the homemade and fresh food, but we have been serving breads, biscuits, cakes to them. So we have to look at the diet and dietitians. Young and all, we always tell our PCO because whatever we say, dietitians give them a strict chart, and because they say we don't eat. Anybody you ask, no, I'm not eating junk food, I'm not eating this. But measured amounts of the proper and good diet. And let me tell you, Indian food of all states, different states, is a very balanced and good food. But people nowadays, and the children especially, they don't eat so much of that food. And exercise.
So I think those are very,
Screen time has increased tremendously, and children are not playing, going outdoor and not exercising.
Okay.
So,
Dr. Prema, 15-year-old girl, will you start her on some oral contraceptives?
That is a very gray area, I would say. So I think cosmetic measures, counseling, whatever helps, first you try.
Things not working.
Then I would.
And which is your favorite, Cervical or the newer Progesterone?
15-year-old, I would hesitate because unfortunately, as Dr. Mother told us, Progesterone comes with 35 micrograms of estrogen. We don't have a separate one. So I would rather go for Progesterone than estrogen in lower dose with Progesterone first.
Within any change of preference, Progesterone, Progesterone?
Oh, similar.
Ciproterol will give you the best results.
Gaurav?
Instant.
You could add a glutamide or spironolactone.
and one thing not to call it oral contraceptive pills when we are eating for this purpose for a 15-year-old.
We will call it hormonal.
Hormonal, I said hormonal.
I agree. Initially the lowest estrogen maybe was 20 mcg, and the one like a Progesterone would be preferable. Progesterone, not so much, and they also give good amount of results. I think at least 6 months should be spent on that when we have decided to start. But we should not just start immediately. Give her time. Make sure that these are not just normal extremes. And if that is not working, then the second line of drug would be spironolactone. And those doses can go up till 50, 100, 200.
But I think you need to be careful once the girl is on spironolactone for two things. One is the blood pressure, and the second is the potassium levels. I think these you need to keep in mind. Priyanka, come to you. This girl is being referred by Dr. Davar to you. I'm not going to be talking about things not so nice. So please pardon my rash. I'm a very soft-spoken, very gentlemanly person. This girl comes and tells you she's sobbing. She says, they call me hairy and fat. Dr. Davar has sorted out my hairy issue. Now you give me a quick fix to becoming not fat.
So first of all, I would take a detailed assessment of what she's been eating at home, because that's what they tell the doctors. We don't eat anything junk. We eat homemade food and everything. So first I will take a detailed recall of from a 24-hour recall to understand the recipes also that are being used at home, because homemade food can also be very oily, fried. So I would also check on how much of oil is being used in the entire month. We have some ratios that we calculate the type of oil that is being used, those things. And whenever they're buying the packaged food items, how to read the labels, because all the packaged foods will say 100% whole grain, sugar free and all of that. But when you check on the ingredients, the first ingredient is the one that will be the largest proportion. So I'll teach them how to read those labels. So that will be general guidelines, and I will do a detailed plan for them, in which I will also take in consideration definitely of how they eat at home, because just blindly giving them a diet just like that without asking what they eat, how are their lifestyle practices and everything, accordingly we would plan. And also we should consider bioactive components as well.
So the 3-point mantra is take the therapy which has been advised, listen to Priyanka's diet, and number 3 is that don't care about what others say. So counseling is
Sorry, not only listen forward. They listen and get it.
Okay, so we move on to the.
One important thing which we missed is kind of metformin.
Yeah, I was going to talk about metformin, but we discuss it in the PCOS piece. So anyway, you could add it.
So that's one thing that we should consider, especially another component of PCOS is metabolic syndrome, insulin resistance. You can see acanthosis is quite common. The metformin not only helps with that, but it also helps with the ovulation and
The cycle regularity.
Yeah.
So we move on to the next case, and
Can I mention one more thing regarding that? So we also need to target at the insulin resistance that is there. And diet and exercise play a very crucial role in that. And only exercising and not getting the added nutrition post-exercise is something that we should consider. Because the strength training exercises like Dr. Shah mentioned in her presentation is very crucial. Once those strength training exercises happen, the insulin sensitivity increases. And once that muscle breakdown has happened, we need to give good amounts of proteins post that exercise. Otherwise, what happens is the body composition goes for a toss. We end up losing muscle mass if it's not supplemented with good amount of protein, and the fat mass increases, leading to again a slower metabolism.
So now this 15-year-old girl, she's now 32 years. Now she wants to conceive. She has undergone multiple cycles of ovulation induction. Ovulation is erratic and occurs occasionally in response to clomiphene 100 milligrams. Her weight is 85. Her BMI is 28. And TVS reveals polycystic ovaries. FSH is 4.5. LH is 11.6. Thyroid is 3.6. Prolactin is 24. Dhruv, I know you have already spoken when you spoke about PCOS, so I'm throwing it to you. So what are you going to do about this lady?
Her ovarian result seems to be good. The quality of eggs seems to be good. So since she's 32, the concern is that, we don't want her to be caught in a state of poor ovarian reserve, which Firoza discussed, where they go into an ovarian failure early. So this problem is not there. So I would first thing is recommend to her to lose her weight. Can I get the previous slide, please? Lose her weight. Her BMI is 28. Bring her down as much as possible. So we say even if you lose 10% of your weight, it's going to help you. Her weight is 85 kilos. I would say drop 8 to 9 kilos and then we start therapy. She can easily lose about 2 to 2.5 kilos per month, and we would expect in the next few months she would get rid of that weight. Advise her how she can lose her weight, give her a exercise as necessary. That is one. The second thing is I would do is, then of course by then hopefully some of them could get normal periods, and then evaluate the cycle. There's one more thing, the TSH is 3.5, 3.6. So when you're planning a pregnancy for a woman, it's been told that ideally the TSH should be less than 2.5. That is what is the ideal assessed. I don't know whether the endocrinologist agrees with me or not, but that is what is recommended. And so I would probably put her on a small dose of Tylenol or any of the thyroid medications. I may want to repeat it once too after she loses her weight. But while she's losing her weight, I want to get her corrected so that at the end of that weight loss, I can start with the therapy. If she has started spontaneously getting her periods, I would do one cycle of evaluation to see whether she's ovulating, she's not ovulating, what's going on with her, and then help her out. So then I would give ovulation inducing drugs.
If clomiphene, I would prefer letrozole.
No, I would prefer letrozole because it's an aromatase inhibitor and known to be good for PCOS patients because they anyway, they get hyperstimulated. So you don't want excessive estrogens going in. With letrozole, you get better results. So I would start her with letrozole, monitor her, do her monitoring with ultrasound or even with an ovulation stick, urinary sticks which they use. And those are also pretty good. Unless, she's very anxious and she wants to get pregnant faster and she's willing to come for ultrasound monitoring, we do that. See when she's ovulating, and depending on the husband's semen report, if he's got a good report, the post-quality test is good, ask for time intercourse. If not good, then we do an IUI, supplement the luteal phase if needed,
and then go to pregnancy. Would you consider ovarian drilling? No. In any patient? Yes, I know she's got LH high. LH high would require ovarian drilling provided she's having what you call a luteinized unruptured follicle coming up all the time. If she's got a very high AMH, if she's lean, if she's had less than 3 years of infertility, they are the ones who respond the best. But I think I would rather not do a surgical intervention initially. But if she's not getting pregnant with the simpler things, then I may want to rule out endometriosis, in which I would want to do a laparoscopy in an unexplained infertility where everything is going well. She's not conceiving. 3 months you try with this, if she's not conceiving, do a laparoscopy, look for endometriosis, and maybe utilize that opportunity as doing laparoscopic ovarian drilling. Then what is your opinion on this? Would you do ovarian laparoscopic drilling?
No, not unless like she doesn't conceive after getting regular
Would
cycle.
you prefer to do a drilling or would you rather put her on HMG, HCG and then see?
But if she's achieved weight loss, hopefully with that she would conceive.
And suppose she's not obese.
Thin lean, probably consider drilling.
Yes, Dr. Dawar, do you have any criteria for ovarian drilling?
So 6 months of this therapy, and if it is not working, then putting in a scope always helps. In addition to endometriosis and PCOS, genital tuberculosis still can be seen only on the laparoscope.
Prema, you're the last.
I don't do ovarian drilling, don't believe me.
So one consensus we have from everybody is no doing ovarian. Once upon a time, all of us have been guilty of that. We did ovarian drilling in unmarried and fat people and all. So I think we should what all of them have said is very clear. There is no place for ovarian drilling just like that. Just because a woman has a PCO, please don't do it. There are very strict criteria where it is justified to do an ovarian drilling.
So let me just present quickly current evidence. Aromatase inhibitors are thought to be the best ovulation inducers in PCOS. Lot of RCTs. Gonadotropins have been said to be as the second line in those who are poor responders with oral ovulogens.
Yeah, this is one more question. Anybody, Prema, if a patient is a polycystic ovary and she's gotten pregnant on metformin and letrozole, routinely would you give a progesterone support? Which and how much?
Madam, I would give.
So
Now
how
that-
much would you give?
That is lot of hit and miss. We can do progesterone levels in early pregnancy and see. Serum progesterone is very low. One would give probably also nitrogenation as immunomodulator, come progesterone, also micronized progesterone, depending on how she has conceived, if she needs HCG support, because if it is ART, then we might need HCG support also, then you give that also.
Yes, Nitin, what would you give? Which progesterone?
I do give progesterone, but the evidence is,
Which do you give? Forget the evidence.
I give micronized. So you believe in vaginal progesterone? Prefer it, but some do have issues with itching. So
yes, Duru, what would you give?
Okay, you're talking about prior to pregnancy?
No, pregnant. You have given her letrozole and she has conceived. Now this patient, would you give, what do you give her for
So
progesterone?
normally I would do her HCG and progesterone on the day when I expect that, we should get a pregnancy test if her HCG is positive and progesterone is low. Then 48 hours later, we are going to review and see whether the HCG has doubled or not and whether the progesterone is rising. In the meantime, I at least start off with progesterone, which I prefer to give vaginal, because vaginal progesterone is absorbed much better than oral progesterone. And then 48 hours later, we check again, and if the progesterone levels are doing well, we continue the progesterone. At least till we have reached about 9 weeks of pregnancy, 9 to 10 weeks, because between 7 to 9 weeks is the corpus luteum, which is supporting the secretion of progesterone. And then the placenta takes over. And during that takeover, the progesterone is low, then there are higher risk of losing the pregnancy. So in short, I like to support till at least 10 weeks.
All of them, Dr. Dawar, would you also give progesterone?
Yes, I will give, but I will give that support till 12 weeks.
So in short,
placenta
all
takes
of them
over.
are agreeing that progesterone support in a polycystic ovary till coccus luteum takes over, whether you do it for 9 weeks or 12, something they are giving. Like next, please.
So the take home message is use progesterone, don't abuse it. Because I don't know, sometimes we've all seen prescriptions where every route of progesterone is given to the patient. Anyway, we move on to the next case, 27-year-old primary, 8 weeks, ultrasound shows corresponding growth, TSH is 12. Dr. Davar, they are worried, they said that 12 weeks baby will come mentally retarded. MTP?
Yes, I would suggest.
Dr. Durusha?
No, I would continue because I think the mental retardation probably comes from hypothyroidism continuing throughout pregnancy. So I would continue immediately, try and correct her hypothyroidism, and it gets corrected pretty quickly.
Okay.
I would also do the thyroid antibodies.
Madam, coming. Gaurav, would you like to only go on a TSH level or think a little beyond that?
So it's important to check the free T4 as well. So that would be the deciding criteria whether they are overtly hypothyroidism. But at a TSH level of 12, yeah, that would not change our management. We would obviously treat it. The difference between just the audience is for pregnant women, the cutoff is 4. In non-pregnant, we would say a cutoff of 10. We would not get excited till the TSH of 10. But there's a big difference between when the patient is pregnant. 4, and I'm sure we'll come to the other parts.
So we worked on the ITS OPSI guidelines in 2019. These are available on the net, and we've talked about trimester specific, but in a low resource setting, if you had a rule of thumb, from 3, we've now said if you have one value which is below 4, still it's okay, and that's what Gaurav is talking about, because our endocrinologist friends said that 4 seems to be more, but as our obstetricians, we develop the trimester specific guidelines, and anything below 3 seems to be a better control. Like you said, the treatment is thyroxine. Just want to ask you, what dose would we start at 12?
So it would be better to start with a full dose of 1.6 per kg. So we would go full out. We would not wait, and we are not in a leisurely situation here. So we would go with a full dose. And if you slightly overtreat here, it's not a huge problem, but we do not want to undertreat the patient.
Okay, what's the best time to do TSH in pregnancy? Because we do it as our first booking.
I think before they even start thinking of conception.
So once she's in early pregnancy, the UPT has come positive. Now, would you do it at 5 weeks? Would you do it at 8 weeks? Would you do it at 12 weeks? As early as possible. Nitin, do you do TSH routinely for all pregnant women now? Yes. Even the national guidelines are now saying this preconceptional checklist that TSH should be done along with HB electrophoresis as routine ANC test. Dr. Durusha had championed the electrophoresis scheme when she was the toxic president. Finally, they've listened to it. We've said we'll wait on this patient, we'll deliver it. Dr. Pankaj Parekh, how is the baby?
Yeah, they are definitely.
Einstein or otherwise?
One of the commonest early cause of mental retardation. After hypoglycemia in babies born of diabetic mother, hypothyroidism is one thing which is very, very important. Now, ideally, most of us do a cord blood testing of TSH. Is a normal routine when we do G6 period routine. Now, the normal value at birth is taken up to 29, also is normal, but it drops to less than 20. Now, the important thing is whether to do a cord blood TSH, very sensitive, 100%, the best time to do after 72 hours of age. But if you do after 72 hours after birth, it is different peak, number one. Number two, many of the young mothers want to go home on the second day, so they do not probably will do. So we do it. If the TSH is high, if there is a doubt, we don't start immediately thyroxine. What we do is repeat the test after 7 days. And that time we do, as he said, free T4 and TSH both. And both are very, very important at that time. Anything more than 20, straight away start hyper. It's now very important to know that the best time to start thyroxine in indicated patient is first 2 weeks of life to prevent complete no problem in cognition and the development. But up to 1 month, there is no problem. So there are very often, very borderline cases where you would like to still wait, but never. If it is still in gross doubt, start the therapy. Don't wait. It's not worth waiting because hypothyroidism can cause significant cognitive dysfunction.
Okay, so I think it's a point well taken, and that's why the Indian government lays top priority on fortification, because we are considered just like a vitamin D deficient state, more importantly, or the diabetic capital, a thyroid or a iodine deficient state. You already know that fortification is a mandatory part of any kind of salt, because we have iodized salt. It cannot be passed through the regulator if it is not, you don't have a fortification facility.
I have one question. So what is the chance of these babies' mental status or mechanism with 12? Because today's mothers are very, very conscious about it, about their babies. And these are not the malformations which we can diagnose on the ultrasound. So it will be ultimately the baby is born. So what are the chances when they ask us what should we tell?
I don't have, but I think I would need to look it up. But I think the chances are it's there, but I would not say 100%.
Madam Negro et al. Came up with the first association, which is universally accepted. Even UNICEF has accepted it. Based on a single TSH level, they do not recommend termination of pregnancy. Yeah, madam, I'm coming to the second point. They say any value which is, they say that at any value it's not really needed to terminate, because they have shown the neuronal development of these babies. And Pankaj Parekh sir will say, agree with me, the maximum neuronal growth occurs at around the 3rd trimester and just immediate after birth. And that is why the aggressive treatment which is required, and hence their explanation is that any value of TSH doesn't require termination of pregnancy. UNICEF has endorsed this because there is, like he said, no direct correlation between X value and mental retardation. That's why if you ask Dr. Pankaj Parekh, shall I terminate this pregnancy, he will say never. The reason why I'm talking of all this yarn is because my better half is a developmental pediatrician, and that's why she always says that no, the best time is that immediately in the 3rd trimester and immediately after birth, they have a spike chart which shows maximum neuronal development. Anyway, we'll quickly go through this case. I'll speak to the endocrinologist first and Priyanka a little later. Same story, everything normal but recurrent miscarriages. Little high TSH, but TPO antibodies strongly positive. How do we approach?
The first simple answer: replace with thyroid. So just
only thyroid or antibodies with some steroids?
No, that's not indicated.
Yeah,
so just delving, because this part is quite complex. There have been lots of evidence to fro. There, the endocrine guidelines, so below 2.5, as you mentioned, is the best to be at. Between 2.5 to 4 is a gray area, and above 4, we don't want to accept that. So this patient, the TSH is also above 4. The anti-TPO antibody is also positive. We would treat. If it's below 2.5 and TPO antibody positive, we are in a dilemma. Generally, the guidelines say do not treat because they are classically euthyroid, but antibody positive. If they have chances of, if they have repeated miscarriages, you may want to take a clinical decision, but the evidence is not greatly in favor of replacing if the TSH is below 2.5. Between 2.5 and 4, if the TPO is positive, yes, you have a case to replace. Okay.
So the moral of the story is that if there is some adverse obstetric outcome which is unexplained and you have got subclinical hypothyroidism, please do a TPO. There may be some justification in explaining the mechanism for recurrent miscarriage. And if TPO is positive, please replace. Even though it's an antibody, no need for this thing.
Even if it is not an adverse outcome, if she has TPO and she has a high TSH, you need to treat any.
Yeah. So if normally, if I may expand a little bit further on this. So if the lady already has hypothyroidism and she's on treatment, then even before planning conception, we would aim for a TSH below 2.5.
Yeah.
But if you see that girl during pregnancy, she comes to you with a TSH of let's say 4 and above, yes, we would want to treat. If it's between 2.4, 2.5 and 4, you are in a dilemma, and
so I think that's where the dilemma, if there is an adverse event, better to keep.
Then we would replace it. And like you said, nowadays guidelines also recommend 3 and 2.5. You can't go too wrong in replacing it. Of course, here when we are in a doubtful situation, we would not replace with a full dose of 1.6 microgram per kg. We would go a little soft.
Okay.
Give dietary advice.
I'm coming. I said no. The second part is preferred. But since now you opened your mouth, I'm going to ask you this question because you are from the legal background. So this is the curious case of progesterone part 2. The first one we've already said. Dr. Durusha and Nitin swore by the heart and gave the answer. Recurrent pregnancy loss, thyroid seems to be the problem. Will you give progesterone, Prema madam?
It will be very difficult to say no to the patient. Because the patient is not asking you. Mother-in-law, mother, and bajuwala's baju.
So I think you don't do any harm. You will give the progesterone. You are here to do good for the patient, and if it is going to benefit the patient.
It will not do harm at all.
Thank you.
This.
Yeah. Priyanka, 2 foodstuffs vegetarian and 2 foodstuffs non-vegetarian because the attention span is greatly reduced. All of us are hypoglycemic, hypothyroid. Okay. So can you please tell us 2 things that you will tell the patient eat and 2 things to avoid if she is hypothyroid?
See, there's no food that you should avoid. The cauliflower, broccoli, cabbage, no need to avoid it. It's just that it has to be properly spaced out between the thyroid medication and the distance between the time you're consuming the food and the medication. So you can consume those food items, but it should be properly cooked. So those are the things that one should take. And to consume, basically in hypothyroidism, the metabolism goes on the lower side. So we can focus on a few food items that boost your metabolism. Like I mentioned previously also, green tea, because it has some bioactive components, cinnamon, and many others that we can focus on.
Okay. And
I'm so glad you said that. I'm so glad you said that. When patients come to us, they have a huge list of things that they have been advised not to eat. Cabbage, cauliflower, even spinach, and the list keeps increasing. Please tear that list. They do not need anything that they do not need to eat. One thing that they must eat, iodized salt, not pink salt and this salt and that salt.
Yeah. Himalayan salt.
Yeah, I think because there are a lot of family practitioners here, we need to emphasize that
That's
because
why
a lot of people have converted to Sinda Namak for God knows what.
Organic namak, Sinda
Pink
namak,
salt.
some pink salt, Himalayan salt. What? If you see Instagram, you will have all these salty things.
Because that namak is supposed to remove your diabetes. Okay.
Blood pressure.
Yeah.
And blood pressure.
So now I think in the next part of the panel, we call it sugar, spice, salt, and now things not so nice. Postpartum thyroiditis. We need to continue the thyroxine way into the postpartum period because she's breastfeeding and all the thyroxine is going to the baby for its development as well. And then do a TSH around anywhere between 8 weeks to 6 months and take a call. The rule of 1/3 become euthyroid, 1/3 become hypo, and 1/3 become hyper. We move on to hyperprolactinemia. 35-year-old, married since 10 years, 2 normal deliveries, last delivery 4 years back, irregular cycles, scanty flow, milky discharge, but It's from both breasts since last 15 days. No history of medications, headache, vision problem, and pain in the breast. Within what medications would you ask? Hyperprolactinemia or rather galactoria? Maybe it's a clinical sign right now.
Which medications I'm concerned about?
Yeah.
Mainly the prokinetics is something, the older generation of cimetidine and TCAs.
Yeah, tricyclic antidepressant.
Yeah, those would be my first concerns. But of course, there are, I think even isoniazid is more to occasionally cause.
Okay. So Gaurav, prolactin obviously we would be doing. Any specifics? When do we do it? Do you need to be in a good mood before?
Yeah, so a lot of things can affect the prolactin levels. It's elevated by stress, excess emotional, physical activity, diurnal variation. So early morning when they're not vigorously exercising.
When do we do an MRI and what prolactin level?
So generally, if it's consistently high, so if I see prolactin level of at least above 80, I would do it. And if it's on a rising trend, if it's moderately high between let's say 40 and 80, I would repeat it. I would not directly jump into an MRI.
And even TSH, right? Because both of them go hand in hand. Okay.
I'd like to say something.
Yes, ma'am.
We have been doing bioactive prolactin now because we know total prolactin gets affected by many factors. And so many times we found that the bioactive or the actual prolactin, which is really raised, is not high. So if you're doing just a total prolactin, we find it high, and a bioactive may be normal. So do you have anything to say about that? Should we just go ahead with bioactive or wait, do total first? If it is high, then do bioactive. What should we do?
I think we can do the total first, and if we are in a dilemma, then we can do the bioactive.
Because unnecessary patients get treated. with
But it's also regards the symptoms. I think if the symptoms are there, then
of course. That's why I didn't talk about the prolactin levels at all because it's going to be a symptom dictated management here. Lover ma'am, have you changed from bromocriptine to cabergoline now in your practice for hyperprolactinemia?
Yes.
Yeah. So I think it's more convenient, it's more effective, less side effects. Prima ma'am, this patient becomes pregnant. If it's a microadenoma causing prolactinemia, are you that worried? Will you continue the cabergoline in pregnancy? If it's a macroadenoma with all these visual changes, will you tell her to terminate the pregnancy, get the macroadenoma operated, and then try again?
She's pregnant, might as well.
Yeah, continue. Yeah, right. So, friends, let's move on to the sugar. It's waiting for you. The spice, and there's a big smile on Dr. Asha Dalal's face. So, from not things so nice, we've moved to all the things so nice. Thanks to the panelists who really helped us and enlightened us. And I leave you with the words of Sri Ravi Shankar, who said that in minds today crammed with thoughts and organs clogged with toxins and bodies stiffened with neglect, there is just no space for anything but disease. It's time to cleanse our souls, cleanse the ovaries, cleanse the uterus, and hope for the best babies. Thank you so much.
Thank you. Thank you for being such a wonderful audience. Thank you.
Before everyone goes, please go to this form memento.